across the world because of associated neonatal mortality and short and long-term morbidity and disability in later life. So this preterm labor we have discussed n number of times, and we all know that the India is at the top. So around 3.5 million cases of preterm labor happen every year. I welcome our esteemed guest and the TNFOG President, Dr. Ramani Devi, and our own President, Dr. Bharati Rajshekhar Kasoga, our Treasurer, Dr. Suman Gaddi, President-elect, Dr. Durgadas Asrana, and maybe the sequence is up and down, but I welcome all my office bearers and delegates, one and all. I welcome now Dr. Bharati Rajshekhar to say a few words before we start this focused program. This program is again under our Jnana Sangam. And this Jnana Sangam is really we have the academic exchange program with other state officials. But this, I thought that we should invite only one person who is thoroughly academician, that is Dr. Ramani Devi. She was my vice president during my tenure as a Food, Drugs and Medical Surgical Equipment Committee. And we also did a few programs on preterm labor. So I welcome her as well as our own president, Dr. Bharati Rajshekhar. I see Dr. Rajashri Palladi also joining the secretary. Welcome, Rajashri. So I want a few words of welcome from Dr. Bharati Rajshekhar.
Thank you, Dr. Vidya. Before my words, I would request that we all invoke the blessings of the Almighty for enriching us and empowering us and to help us do better to those women who come to us in trouble. Arun, could you please play the invocation? Yeah, thank you. Thank you, Arun, for this melodious invocation and also illuminating the session. And I would, my pranams to all the esteemed faculty here. And true to lighting of the lamp, we have our esteemed guest, Dr. Ramani Devi Madam, who is indeed a luminary, who is here to enlighten us and also clear our doubts of whatever we have on preterm labor. And Dr. Ramani will now be, me and Dr. Ramani will be moderating a panel on preterm labor, and to be with us on this very, very important panel, because whatever advances have happened in technology, still we do see preterm labor, which is quite common, contributing to an increased incidence of infant morbidity and mortality in our country. And Dr. Vidya Thobi has been very kind enough to convene this meeting and make it a very productive one. And on behalf of Kasoga, I would like to welcome Dr. Vidya Thobi, who is our immediate past president, Dr. Durgadas Asrana, who is the one who is going to be taking the baton from me. He is the president-elect. And we have our secretary, Dr. Rajashri Palladi, and my treasurer, Dr. Suman Gaddi, who is always there right on time or even much before time. I extend my warm welcome to you. Due to unavoidable circumstances, we do not have our patron and Chief Patron, Dr. M.G. Hiremat, and our patron, Dr. Nagraj. But still, I express my pranams to them, who have been the guiding force of Kasoga down the ages. And we stand here because of the effort being put by Dr. Hiremat and Dr. Nagraj. And of course, we have a very, very eminent academicians here participating in the panel. And I would like to welcome on behalf of Kasoga, the moderators will be Dr. Ramani Devi and myself, and we have experts true to the name. Dr. Vidya Thopi and Dr. Durgadas will be the experts for the session, giving their expert comments in the panel. And of course, the luminaries we have on the panel are our past president, Dr. Kasturi Jonimath, and Professor at HOD retired from Hubli Medical College. We have Dr. Rajeshri Paladi from Gulbarga, Rupa Prakash, retired professor and HOD from Mysore, and we have Rajeshri Eliwal from Gulbarga, who is the HOD of Gulbarga Medical. She from Bijapur. And I have Dr. Sunita and Dr. Shubha Ramrao. So, true to the words of Gyan Sangam, we've got people from the north, south, east, and west of Karnataka here on this panel. So, I welcome you all to this panel. I welcome all the delegates who are eagerly waiting for this interesting discussion. And I also welcome the Abbott Company who are sponsoring us this program. And last but not least, I would like to say that Dr. Ramani Devi Madam has occupied many chairs as in her capacity in Tamil Nadu as well as in FOXI, but now Madam wants to step in to another very decorated position in FOXI, that is the ICOG chair. And on behalf of Kasoga Madam, we wish you all the best, and we are with you, and definitely we would like to see you as the ICOG chair. And of course, I am also trying to step into some position in the FOXI, and Dr. Vidya Thopi has already, she has been elevated from the chairperson, and she's been unanimously, I think, will be elected as the vice president of South India. But still, she is very much interested in carrying on academics all over, and she is the one who is pushing me and mentoring me into FOXI, where I will be contesting for the Perinatology Committee as a chairperson. I request all of you to kindly express your solidarity and support. I know you always stood by me. So without wasting much time, I would like to hand over the session to the chairpersons, Dr. Rajeshri, who will take over, and we will start the panel. Thank you very much. And thank you, Dr. Vidya, for making my job easy.
Thank you very much, and I wish all the best for Dr. Bharti as well as Dr. Ramani. She was also a mentor for me for all my activities. So all the best, Dr. Ramani. And she will, of course, Dr. Ramani is a Tamil Nadu president for the OBGYN Societies of Tamil Nadu, and Bharti is a president of Kasoga. So I have joined both of them for the panel discussion, and I actually wished all the office bearers as a panelist, but somehow we have got the others also, like Dr. Sunita had joined, Dr. Rupa Prakash, and Dr. Rajeshri Eliwal is going to join shortly. I would like to I am going to talk something about overview and I'll be sharing my screen. So I think I'm the host, so I can share. I'm trying to share now.
Yes, ma'am.
Yeah.
So before you start, Vidya, I think I thank the Kasoga, the office bearers, and the all the members for having invited me to this very important topic on preterm labor. And I also thank them for canvassing for me, and I hope I will be up to the mark and I can do something what I can to the best of my ability as a vice chair of ICOJ. And I also wish that Dr. Bharti should succeed in her venture. And I also congratulate Dr. Vidya Thopi. I know she has been elected as vice president of FOXI without any opposition. And I thank all the members, and I thank the faculties as well as the participants of this very important webinar for having joined today. Thank you.
Thank you, madam. And I think our own past president, Dr. Kasturi madam, is also going for the quiz committee.
I know
my apologies. Kindly, I would request all of you to kindly support madam also.
I think unless we stand with solidarity in the South,
madam.
South cannot have representation.
So, very true, madam.
It is my wish is that all the members from the South Zone should definitely vote for our own members. That is the only way where South can come up in the Central FOXI.
Very true, madam. Very
I
true.
request every one member of the South to
Vote.
vote without
Vote.
without fail.
Yes.
That is the only thing. If we vote, because our next
Yes.
to West Zone, we have the maximum number of voters.
Votes.
We differ from West Zone only by a margin of 500 votes. That's all, 500 members. So I think we have to cast all our votes and so show our solidarity.
Very true, madam. Very true. Over to you, Dr. Vidya.
Thank you very much. Really, it is always inspiring to listen from Dr. Ramani, and always she was a force to stand behind me whenever I did any activities in Foxy as well as Kasoka. Dr. Rajashri is here and she wants to speak something. I can see from her face. Yes. Yes, Rajashri.
Namaste. Good evening, everybody. And hearty congratulations, madam, for floating this a very much awaited panel discussion on preterm labor, which is so meaningful in the day-to-day clinical practice. And with the guidance of stalwarts like we have Dr. Ramani Devi, who has been so instrumental in spreading academics and knowledge all over South India, and talking of solidarity of the South Indians to stand together. Yes, very much true. We are all there to be led by our leaders. And congratulations, Vidya ma'am, and best wishes. We are all there, Bharti ma'am and Kasturi Dhonimat ma'am. Together we can. That is all I can say. And over to you, ma'am.
Thank you. So whenever we talk of preterm labor, always we talk of prediction and prevention is always better than cure. An ounce of prevention is worth a pound of cure again. So my flow of the content of the topic today is again divided into various subtopics. Like we want to discuss mainly the interventions, what we can do for the management of preterm labor. We always discuss about this, that it is a major public health problem and how we have to predict and prevent this. And it is very alarming to say that India tops the list, and we have to cross this. Why this is happening in India only? What are the factors and what are the epidemiology? Always we discuss. Preterm labor, we know the definition, that is birth between 7 weeks of gestation and 6 by 7 weeks of gestation. And it is always, there is an onset of some uterine contraction of adequate strength and frequency, which is causing progressive dilatation and effacement of cervix before 37 weeks of gestation. Again, it is subdivided into subcategory like extremely preterm, less than 28 weeks, very preterm, 28 to 32 weeks, late preterm, 32 to 37 weeks, and suspected threatened preterm labor when there are uterine contractions without cervical dilatation. Diagnosed preterm labor, uterine contractions with cervical changes, and established preterm labor when there are uterine contractions plus progressive cervical dilatation more than 4 centimeters. There are certain definition one should know always, like what is suspected threatened preterm labor? These one should always know whenever we are going to treat the patient. Many times the patient come with established preterm labor, then we cannot manage these patients and we have to attend to the preterm delivery itself. So preterm labor, one syndrome, many causes, we all know. Maybe it can be a uterine distension, or there can be any breakdown of the maternal and fetal tolerance because of various reasons. There can be some bleeding, subchorionic bleeding, antepartum hemorrhages. These are some of the causes, and sometimes the cause is also unknown. So it is a pathological condition with multiple etiologies. So it is also termed as preterm parturition syndrome. There are various risk factors for preterm labor. They are maternal, or it can be a past obstetric history, or there are some of the uterine factors. We all know about it, so I will not go into the various discussions of the risk factors. But one should also have the predictable causes of preterm labor. We should know these predictable causes. When there is a past history of preterm labor, when there are uterine abnormalities, cervical abnormalities, advanced maternal age, and most important is the assisted reproductive technologies. So previous preterm birth is the strongest risk factor for the future preterm delivery. So one preterm birth, 14 to 22% of the risk, two preterm births, 28 to 42%, and 3 or more, up to 75% of the preterm birth risk is there. So this is a etiopathogenesis. There's so many factors which is going to lead to preterm labor. Either it can be a premature rupture of membranes, infections, barrier in the decidua, that is abruption, uterine malformation, Mullerian anomaly, cervical insufficiency, or that can be activation of maternal and fetal HPA axis, or fetal abnormalities like abnormal presentation or fetal growth restriction. Ultimately, it leads to increase in the fetal inflammatory response syndrome, and which leads to, again, the release of prostaglandins and cascade. So preterm birth can have far-reaching health consequences in the child as well. So complications which are seen in the preterm babies are neonatal, RDS, we know, intraventricular hemorrhage, periventricular leukomalacia, necrotizing enterocolitis, patent ductus arteriosus, increased susceptibility to infection and metabolic abnormalities. Short term, we also have neurodevelopmental difficulties, transient dystonia, retinopathy of the preterm babies, and increased susceptibility of the infection. And if you follow these preterm babies, there is again increased risk of cerebral palsy, sensory deficit, incomplete growth catch-up, cognitive impairment, behavioral abnormalities, and chronic lung disease. So these are the consequences we are really bothered. So how we have to diagnose preterm labor? One first thing is very important is history taking, past obstetric history and current symptoms. And sometimes these current symptoms are very vague. She will just tell you that she has just a pain abdomen or some uneasiness or backache. Then comes the physical examination. Per abdominal examination is very important to know how many contractions are there. And of course, some of the contractions cannot be pursued by your hand or by the mother. And sometimes there is a difficulty to know how many contractions are there. Then we can have a cervical length and cervical effacement examination. This can be again, we say that there is again, digital examination is again controversial because there is again intra-observal. There is deficits, means one person will say the cervical length is less. Some persons, doctors, they will examine and they will say that this is a short cervix. So it is very difficult. So ultrasound is the best method to measure the cervical length. The investigations, that's what I was talking about. These tokometers are not useful. There are very many studies which are available by home monitoring and all those things. So these things and the biochemical screening again. So when we are going to do this evaluation, that is initial assessment of women with the preterm contractions, first most important is the gestational age less than 37 weeks. To label this as a, please can you mute them?
Arun, please mute others.
Yes, ma'am.
So one
Yes,
is noting the correct history, clinical history, and ultrasonography can tell you the gestational age, whether the membranes are ruptured, whether really the patient is in labor, is there an infection, and what are the likelihood that the patient will deliver prematurely. So these are some questions we should answer. Second thing is there are challenges in the diagnosis of preterm labor. The risk factors are not reliable indicators, and 2/3 of the patients with risk factor do not deliver preterm. And half patients who deliver preterm have no risk factors. Second is method of evaluation. They are underused. So normal cervical length and negative rapid fetal fibronectin, 98% deliver at more than 35 weeks. And short cervical length and positive rapid fibronectin, 50% deliver at 37 weeks. And there is a lack of standardized protocols. So standardization will allow timely interventions and transport to the higher level of fetal acuity, avoid unnecessary and antenatal treatment. So these are the three challenges which we face. The prediction, when we talk of, most important, the prediction is a history of prior preterm birth, the decrease in cervical length and symptoms of preterm labor, and some biochemical markers which are extensively studied like fetal fibronectin. So these are the estimated recurrence risk of preterm labor before 35 weeks in women with previous history of preterm labor. So if the fetal fibronectin is positive, the cervical length, if it is less than 25 millimeters, 65% chance, 26 to 35, 45% chance, and more than 35 if the cervical length is only 25%. So it has got a prediction. It can predict. So when to measure is the cervical length? The cervical length measurement using transvaginal or transperineal ultrasound. Of course, it also requires the expertise to put the probe. The usual timing is 20 to 24 weeks, and any time in patient with increased risk of preterm delivery. So when they do for nuchal translucency NT scan, that time also you can just measure the cervical length. The dorsal lithotomy position is given, and these are the ISUA guidelines. So internal os is denoted by V-shaped notch when you put your transducer, and external os is denoted by triangular area of the echo density. So you have to measure, and the anterior and posterior wall should be of the same thickness, that you have to note. So these are the various shapes of cervical funnel and how it has to be measured. This takes another class of our lecture. So I will not go into the details of this. And another treatment modality is the cerclage. So we know that the rampant use of cerclage. So elective cerclage is recommended when there is a clear anatomical defect involving or near the internal os, or 3 or more second trimester losses, or inability for follow-up and with reliable sonography. There are ACOG recommendation for cerclage, and it is indicated in second trimester with singleton pregnancy who have history of second trimester pregnancy loss, which is associated with painless cervical dilatation without labor. So have had cerclage in the previous pregnancy due to painless dilatation, and currently have painless cervical dilatation. So these are the certain ACOG recommendations. So in some patients, it is not at all recommended with short cervical length in second trimester without a history of preterm birth. So SOGC also has got its own guidelines, and the Cochrane review says that cerclage probably leads to the reduced risk of perinatal death when compared to no cerclage. So in some patients, when the cervix is short, we always give the progesterone, no doubt. But in some patients, if there is an anatomical defect, then definitely you have to put a cerclage. The pregnant woman with cerclage they found that in Cochrane review, they were less likely to have preterm birth compared to controls before 37, 34, and 28 completed weeks of gestation. Even SOGC has got its own clinical practice guidelines, and they say that it should be considered in singleton pregnancies in women with a history of spontaneous preterm birth or possible cervical insufficiency if the cervical length is less than 25 millimeters before 24 weeks of gestation. So sometimes we have to give the rescue cerclage after the cervical dilatation, and in some patients that may delay delivery. There are so many case reports delay the delivery by 5 weeks. And this we do for allowing the steroids to act or plan for any in utero transfer to the center with the NICU facility. So management of preterm labor, we always manage, we want to do this in utero transfer to the tertiary care setup facilities for neonatal ICU. And initial treatment is, we want to give steroids. And of course, if there is a evidence of infection, or if there is a PROM, or if we suspect the chorioamnionitis in those patients, we give antibiotics, and tocolysis are to be considered in case of threatened or diagnosed preterm labor and we want to shift these mothers to better facilities. The neuroprotection, again, the magnesium sulfate to be administered in the gestational age between 24 to 32 weeks. The loading dose is 4 gram IV bolus over 20 minutes, and maintenance is 1 gram per hour over 24 hours till delivery, whichever occurs first. So each day of delay in delivery increases the survival rate by 3%. That's why we want to manage these patients for betterment of the neonates. So role of corticosteroid, we all know it has got a beneficial intervention, and it is strongly associated with the decreased neonatal morbidity and mortality. Single course of corticosteroids is recommended for pregnant women between 24 to 34 weeks of gestation who are risk of delivery within 7 days. And because of this treatment of corticosteroids for less than 24 hours, it is associated with, again, reduction in morbidity and mortality. And first dose of antenatal corticosteroids should be administered even if the ability to give the second dose is unlikely. So based on the clinical scenario, so 2 doses of 12 milligram of betamethasone is given intramuscularly 24 hours apart, or 6 milligram of dosages of dexamethasone every 12 hours administered intramuscularly. And we know what is the mechanism of action. It improves the lung mechanics and accelerates the development of type 1 and type 2 pneumocytes. So many advantages of giving corticosteroids. And we have already told that when it's to be given, but what about more than 34 weeks? It is really controversial, and it has got some inconsistent data. Even few people, they say even 36 weeks, if you give steroids, it is helpful. So it significantly does reduce the risk of RDS and intraventricular hemorrhage and even neonatal death. So what about the choices of drugs? It is commonly this question comes, and Government of India always endorses dexamethasone. Betamethasone salt is not available, and whatever available is not stable, heat stable, and we have to give multiple dosages. What about the role of magnesium sulfate? It confers the neuroprotection to the neonate, and it is used for this benefit. So intravenous magnesium sulfate should be given between 24 to 29 plus 6 weeks of pregnancy who are in established preterm labor or having planned preterm birth within 24 hours. Like severe preeclampsia, we are going to do some elective termination of pregnancy. In these patients also you can give. So in intervention, a loading dose, same, I have already told you the dosages previously. The maintenance dose should be given 1 gram per hour until delivery. So this is based on the modified Beam trial protocol. So various tocolytics one should discuss. I think in the past, my one lecture, I talked too much about tocolytics. So I will just brief it. And these treatment goals are about for the delay of the delivery for at least 48 hours when it is safe to do to act these antenatal corticosteroids, either primary or rescue, which are given to mother to have time to achieve their maximum fetal or neonatal effects. And it should also be given for providing some time to safe transport for to the facility. Of course, and to prolong the pregnancy, it is questionable. Some people, and there is a lot of discussion in my future slides. Of course, we can discuss more in our panel discussion also. How many days we can give this tocolytics and all those things. So what happens is when some patients, we don't want to prolong the pregnancy, like acute pyelonephritis is there, abdominal surgery is there. So these patients, they can go in for the recurrent preterm labor. In these patients, how many times we have to give tocolytics? That is again a question mark. When we should give the period of gestation where the tocolytics are given, that is up from 24 to 34 weeks. What assessment you should do prior to the tocolytics? One is important is the gestational age. Some people, they know their correct LMP, then we have to confirm the gestational age by various methods. We all know the ultrasonography, Doppler, all those things, and have to confirm correctly the gestational age. We have to assess the fetal well-being, fetal growth assessment, and evaluation of any congenital anomalies are there which are detrimental. Then definitely we have to ask her to terminate rather than continue the pregnancy. Drugs used for tocolysis, there are various classes. We know beta agonist, isoxsuprine and retardin, oxytocin antagonist, that is atosiban, nitric oxide donor, that is glyceryl trinitrate, calcium channel blocker, nifedipine, and others like magnesium sulfate and indomethacin. And this is a mechanism of action which is currently available tocolytics. So they act at the various levels, we all know. So most effective are the calcium channel blockers, which we are commonly using, and beta agonist and prostaglandin synthetase inhibitors. These are the most effective tocolytic drugs. And less effective are, of course, oxytocin receptor antagonists, nitric oxide donors, and magnesium sulfate as a tocolytic. So these are the various contraindication you must know whenever you are giving for tocolytics, like if there is a lethal fetal anomalies, if the already baby is dead, or there is an infection, or any maternal indication for that drug for to give the tocolytics, you should not use those tocolytics. There are certain limitations of currently used tocolytics, and these are the we all know that we have to focus on the myometrial cell, which has to be which we want to relax. So these whatever available tocolytics are there, they act on various non-myometrial tissues also. Like beta adrenergic receptor agonists, they also act apart from the uterine musculature, they act on the various other skeletal muscles and liver also. Calcium channel blockers, they act on cardiac conduction and vascular smooth muscle. Magnesium sulfate is again, they act on neuromuscular junction, they cause neuromuscular junction blockade. Nitric oxide donor, vascular smooth muscle. Okay, so apart from this oxytocin receptor antagonist atosiban, no tocolytic has been specifically developed for the treatment of preterm labor. So these are the various class of drugs primarily licensed for something else, and we are using for as a tocolytics. Beta adrenergic agonist is primarily licensed for the bronchial asthma, cyclooxygenase inhibitors for inflammation, pain, fever, progestogen as a hormonal substitutes or hormonal treatment, magnesium sulfate for eclampsia and hypomagnesemia sometimes, and calcium channel blockers for hypertension, and oxytocin antagonist is the only drug which is for the tocolysis. So no other tocolytics are uterospecific, so only apart from atosiban. The poor safety profile also, we should know about the available tocolytics. We know that beta mimetics are contraindicated in cardiac arrhythmias, and diabetes also, because it causes hyperglycemia. It has got plenty of maternal side effects like myocardial ischemia, hypotension, hyperglycemia, cardiac arrhythmias, and neonatal side effects like tachycardia, neonatal hypoglycemia, and hypocalcemia. Nifedipine is known to cause hypotension and tachycardia and should not be given in cardiac diseases. So it should not be given also in concurrently with magnesium sulfate. Indomethacin, we all know that it causes constriction of ductus arteriosus, pulmonary hypertension, and oligohydramnios. So usually whenever there is a polyhydramnios and patient comes with the preterm labor, so it can be given less than 32 weeks if the patient is, then we can refer indomethacin. So nitric oxide donors, GTN patch causes neonatal hypotension as well. So these the poor safety profile everybody should know. And this is a simple chart which depicts all the dosages, mechanism of action, side effects, contraindications, and interactions with anesthesia also. This is very useful chart, but I will not go into the details of this chart, and I will just highlight few of the drugs which are commonly used and what exactly one should administer when the patient. We should be very much tailor-made treatment. We have to study which patient, which drugs you should use. Now here, whenever we are using atosiban, we should know about the maternal side effect. Usually, not many side effects are noted, but only hypersensitivity or some injection site reaction they have noted down. The fetal side effects is atosiban crosses placenta, but there also they have not noted much any side effects in the fetus. So contraindications are none, but one should be very much should be you should know about how you should use it. You should have to do titration. You should know the dosages. You should have an infusion, or you can simply put bolus of 6.75 milligram followed by 100 microgram per minute infusion for 3 hours, and then 100 microgram per minute for 45 hours. So there are no absolute contraindication as such for the atosiban. So what is the expert opinion for the in the Indian clinical setting? So atosiban is effective and well tolerated. It can be used in cardiac patients and even in the rheumatic heart disease, but it is very, very expensive. And also the dose titration is complicated, requires a constant monitoring. Indomethacin, I told about the constriction of ductus arteriosus, so it is not at all recommended after 32 weeks. And before 32 weeks also, there are ductal effects if the duration of therapy exceeds 48 hours. So you should not exceed indomethacin about 48 hours. The rectal pessaries also, they say that you should give, you can give rectally also 50 to 100 milligram loading dose, followed by 25 milligram orally every 4 to 6 hours. This is a ideal dose of indomethacin. So there are maternal side effects also, and they say that some platelet dysfunction may occur. So these are the side effects and the dosages. And another thing is concomitant use. I already told that calcium channel blocker and magnesium. This already I have told. So about the nifedipine, what is a Indian clinical setting expert opinion? Nifedipine is preferred by some due to the ease of administration. It is always an off-label prescription which we give. And the use of nifedipine, it has not been authorized by CDSCO for managing preterm labor, and it is not at all licensed for the use of pregnancy for preterm labor management. So this one should remember when we are using nifedipine. Beta-2 agonists are extensively studied. I want to focus today about isoxsuprine. And isoxsuprine is beta-adrenergic receptor stimulator resulting in uterine relaxation and vasodilation. It was the first tocolytic agent to be successfully used. Strong inhibitory effect on the muscular tissue of the uterus and blood vessels, and most importantly, it is approved by the DCGI. It has got a direct relaxant effect on the smooth muscle fibers, stimulation of beta-2 receptor mediated relaxation, and alpha sympatholytic activity. The maternal side effects are many, but they can manage. They are manageable. One thing it causes is maternal heart rate, increases the stroke volume, and there is also the stimulation of beta-2 adrenergic receptors, like there is a peripheral vasodilatation, diastolic hypotension, and bronchial relaxation. So fetal side effects, these all beta agonists cross the placenta. Fetal effects such as fetal tachycardia are analogous to the maternal effect. And there is a maternal hyperglycemia and neonatal hypoglycemia that causes a fetal hyperinsulinemia, and that is a main side effect. Fetal acid-base status and neonatal well-being are not compromised by these agents. So these are the common. Because of this, there is a tachycardia, hypotension, palpitation, shortness, and only few cases of pulmonary edema. So we have to monitor these patients very much. Contraindications, one should know when we should not prescribe isoxsuprine, that is tachycardia, sensitive cardiac disease, poorly controlled hyperthyroid or diabetes, you should not give, and use with caution in women with high risk of massive hemorrhage, because it causes again relaxation, and again the bleeding will increase. So we should always be careful. How to administer this isoxsuprine? Earlier, it was very, very popular drug. And now also it is coming in vogue because there are many studies are published and many people are taking as a research and a routine administration. If you want to give isoxsuprine intravenously, 4 ampoules to be given in 500 ml of 5% dextrose or Ringer's lactate. Start the dose with 8 to 10 drops per minute. Increase 8 drops every 15 minutes till the uterus becomes quiet. Maximum dose should not exceed 0.5 milligram per millimeter per minute. The monitor blood pressure and dose can be titrated as per the response of the contractions of the uterus. The intramuscular administered at the onset of preterm labor only if the facilities for IV administrations are not available at the periphery, and it is continued until control is obtained on the symptoms of preterm labor. It can be administered subsequent to 24 hours of IV infusion. So 10 milligram every 1 to 2 hours you can inject. But again, you have to monitor her pulse and blood pressure. Now, it can be followed by the oral administration should be subsequently. You can give after the uterine activity has been completely subsided, 60 to 80 milligram daily in divided dosages is the usual maintenance dose. And then how long you can give this isoxsuprine? Some people have given almost, they have given till 36 weeks. And there are various studies also available, but I have not done this study for the till 36 weeks. So this is a study which is from our, it is a multicentric study, I must say. Our Vaishali Chavan Perinatology Committee chair, as well as our, it is done in, one center was in Bijapur. So this study I just want to quote, and there was a comparison of prophylactic agent for the better perinatal outcome. So they found that this isoxsuprine prolongation of delivery for at least 48 hours was seen in around 57.69 patients. And birth weight also was higher, and the latency period was also higher. And Apgar score was also higher. So isoxsuprine, they found that it is very, very useful. And in other study, when they compared, the prolongation with nifedipine was very less, only 34% of the patients. So and they have compared with nifedipine, and they found that isoxsuprine is very, very useful. I wanted to just comment on this maintenance tocolysis. Almost all 50% women who are treated for the acute preterm labor ultimately experience preterm delivery. So role of maintenance tocolysis is to promote uterine quiescence and prolong the interval between acute preterm labor episodes. After successful treatment of acute episode, the woman remains at risk of recurrent preterm labor, need for hospitalization, and retreatment with intravenous tocolytic agents and preterm birth. So what are the FOXI recommendation for on oral maintenance therapy? So FOXI recommends maintenance therapy basis, that is Indian studies with encouraging results with isoxsuprine was used in the maintenance after the arrest of preterm labor. So these were the studies. One was Dr. V.K. Singh and other Dr. Jaju, who is also in the delegate. So he can also comment on this. So he also studied this, and they found that, but the whatever the study they did, how many means the sample size was very less. So we have to do many more studies that we can increase the means if you give this maintenance tocolysis with isoxsuprine, we can increase the latency period as well as prolongation of the gestation. Comparison of different tocolytic agents were done, and the approval status in India, and what are the FOXI recommendation. Now, isoxsuprine hydrochloride is a CDSCO approved medication which is utilized in India for over 6 decades. And in India, use of nifedipine has not been approved by CDSCO for the management of preterm labor. Nevertheless, the innovator has confirmed that an expert opinion which was published in 2014 that nifedipine has not been licensed. FOXI recommends the isoxsuprine for the management of preterm labor, and FOXI's statement on the use of off-label drugs on preterm labor, even though the Western guidelines mentions these agents in management of preterm labor, in India, CDSCO has not approved its usage. WHO approves nifedipine. When we compare different tocolytic agents again, Even the guidelines from the National Heart, Lung and Blood Institute advise clinician not to avoid concomitant use of administering the calcium channel blocker and magnesium sulfate. And RCOG guideline, there is a relative contraindication to use nifedipine and the magnesium sulfate. So we should not combine these two drugs. And most of the time, the patient severe preeclampsia goes into the preterm labor, and sometimes we have to terminate the pregnancy also. What is the regulatory status? The Minister of Health and Family Welfare said that it is indicated in preterm labor. It is a Schedule H drug, which is approved by CDSCO. And there is a monograph which is given in the National Formulary List, which 2016, which is published by Indian Pharmacopoeia Commission, Ministry of Health and Family Welfare, and European Medicine Agency assessment also. It is a short-acting beta-adrenergic agonist like salbutamol, terbutaline, phenytoral, ritordine, and hexoprenaline, and isoxaprine for obstetric indication, concluded the benefit of parenteral formulation outweighs the risk in short-term management of uncomplicated tocolysis. The parenteral product should only be administered for up to 48 hours in patient between 22 and 37 weeks, not beyond that. So the expert opinion again for tocolytic in Indian clinical setting, isoxaprine is the first line of tocolytic agent used by 80% of the panelists, 80% of the doctors. They have done a survey in amongst the Indian doctors, and I feel that at the peripheral part, they use this isoxaprine. Even tablets they are giving. So IV isoxaprine, maybe they're not giving, but the tablets are very commonly used. IV isoxaprine is a preferred drug for the managing the active preterm labor. The IV route of administration provides the advantage of titration. We can reduce also the dosages to minimize the side effect. And this dose, whatever IV IM we are giving, it is followed by the 10 mg oral dose of isoxaprine for 4 to 5 tablets per day after food. And the patient should be in the left lateral supine position to avoid any side effects. Of course, I always advise whenever I give isoxaprine for the monitoring of blood pressure and the pulse, as well as the other features like whether the patient is breathless and all. We have to monitor them carefully whenever we are giving IV or IM injections. The efficacy of isoxaprine is 80 to 90% based on the expert clinical experiences. So there are many Indian studies which are available of this isoxaprine injections. And beta mimetics, they help to delay birth, which may give to allow a woman to be transferred to the tertiary care, which is our main aim to complete the course of antenatal steroids. So there are so many comparison of all the beta mimetics. Now, role of progesterone is another chapter. I don't want to discuss much because we all know we routinely use progesterone. I think much will be discussed in our panel discussion. I'll just scroll through my slides in this. So I will not much talk about this. So we all know that how to give the progesterone and at what level they act. We know that it maintains the uterine quiescence by acting at all the 4 sites. And there are so many publications, so many literature which is available, and we all know that progesterone is very useful for the maintenance of uterine quiescence. There are so many international guidelines and references and the various routes how we can use and in which cases it is used. Only thing is questionable is 17-hydroxyprogesterone. Now they say that it is not very useful. The earlier literature said that it is very injected, like we used to do this injectable progesterones. And one thing you should remember that these progesterone therapy in normal healthy pregnancy unnecessarily for prevention of miscarriages or prevention of preterm labor, we should not give here and there. I have seen many cases of liver dysfunction also for the excessive use of progesterones. So commonly they give in ART cycles and that is continued. And they also have very questionable and debatable debate on progesterone therapy in multiple pregnancy as well. So what are the advantages and disadvantages? That is again a debatable thing. There are various progesterones which are available: oral, micronized progesterone, vaginal, intramuscular, all those things. And they are very useful, I must say. And there is a robust evidence on the latest guidelines. And these are the guidelines and how to use these progesterones. These are the some of the studies I had taken for the progesterone, but I'll just keep them because of shortage of time. And I am very much keen in participating the discussions, which we will be talking, and we are including this progesterone in the management of maintenance of as a maintenance tocolytic progesterone in the management of preterm labor, which we will be discussing when Dr. Ramani and Dr. Bharti will be talking on preterm labor cases. So let us discuss the practical points, how we can use this progesterone as a tocolytics. Another question comes whenever about the use of antibiotics, and we should remember there should not be routinely needed for all cases when there is an intact membrane. Exception is infection, if there is a established labor, and if we want to give group B streptococcal prophylaxis, regardless of GBS status or membrane status, some people they give. And if we know that there is a evidence of chorioamnionitis in this patient, ampicillin, gentamicin, and metronidazole, all three should be given. And if penicillin hypersensitivity is there, then clindamycin, gentamicin, and metronidazole should be given. And we know that co-amoxiclav should be avoided. We know why also. So these are the recommendations: uterine contraction and cervical dilatation, that is threatened preterm. Immediate measure, you can give tocolysis, parenteral isoxsuprine, atosibon, corticosteroid, and magnesium sulfate. And maintenance can be given by giving isoxsuprine hydrochloride orally. Of course, I don't recommend now because evidence is there that 17-hydroxyprogesterone weekly should be avoided. If there is an established preterm, then we have to plan for delivery where there are NICU facilities, give magnesium sulfate and rescue corticosteroids. And if immediate measures, you always, when it is diagnosed, we have to transfer the patient to the tertiary level, you have to give tocolysis again. So this is a common protocol. And when there is a PPROM without infection, not in labor, same we have to take as a threatened preterm labor. And if there is an infection, definitely we have to treat as a established preterm. We have to monitor this patient for the infection and deliver as early as possible. So Indian studies, many are available, and they prefer isoxsuprine as superior to other drugs. Atosibon is very costly and it takes much time, and nifedipine is off-label. It has got its own side effects. So isoxsuprine, if it is given correctly and monitored properly, it is a drug of choice. So these are the DCGI approved drugs, and it is always isoxsuprine is preferred. Practice pattern, retrospective studies also confirm amongst all pharmacological agents, this isoxsuprine has showed better improvement, maternal and perinatal outcomes. So when administered intravenously or as a maintenance therapy, it is very effective in prolonging pregnancy. So it is safe also and well tolerated also. Monitoring, as I told as a monitoring is very, very important. So 40 milligram oral tablets has got good patient compliance and good perinatal outcome with this tablet maintenance properly. So what are the interventions which prevent late preterm? So progesterone, surgical closure when there is, if indications for cerclage, and prevention of exposure to various environmental toxins, judicious use of fertility treatments, and dedicated preterm birth prevention clinics. This is another concept that is prevention preterm birth clinics are coming up. So the intervention and prevention is primarily aimed for all women, primary. Secondary, eliminating the reducing risk in women with the previous preterm birth. Tertiary, aimed at the preterm infants. So we should aim at following measures: smoking cessation, tobacco chewing, family planning, improved nutritional status, avoidance of late preterm births. In nutrition, there is evidence of omega-3 fatty acids, and they say that if you give, then definitely it prolongs the pregnancy. Secondary prevention, the risk factor of preterm birth, we have discussed. Any past history of previous preterm birth or any uterine anomaly, any cervix there is an anomaly, think of cerclage, any present pregnancy risk factor like multiple gestation, infection, very obesity, or very low BMI also, think of how we can treat this. Measures, we again the progesterone, they say, cervical cerclage and dedicated clinic and we also can have specific clinics where the tertiary care and NICU facilities are available. So this is a tertiary prevention after the parturition process has begun. So one is preventing delivery or improving outcome for the preterm birth by referring to the regionalized perinatal care center. So where the NICU facility and trained neonatologist is available. Only that NICU is not enough. We have to have the trained neonatologists who are available. So this is what is a key home, what we have to study more on isoxsuprine as a molecule and how we can treat our patient with this molecule, because this is relatively cheaper one, but the injection when we plan for that monitoring part is again very difficult, because many of us, we have seen that if there is a multiple pregnancy and if you give, I have seen one case of pulmonary edema. Yes. So if monitoring is done properly, this is a drug of choice. So at the end, I just want to conclude that we all know that preterm labor is a major public health problem. Prevalence is around 21% and incidence is increasing. And also we have to bother about the short-term and long-term morbidity and mortality in survivors. Those are the neonates. And all efforts should be made to prevent not just early, also late preterm birth, and to avoid iatrogenic prematurity unless strong obstetric indications are present. Thank you for the patient hearing, and let us listen from the very great academic session next. That is, I think, very good panel is going to happen next. So thank you very much. So I'll be joining that panel also. Thank you very much.
Excellent, Dr. Vidya. I think, am I audible?
Yes.
Yeah, so that was a very exhaustive talk with covering all the topics of preterm labor, from the morbidity to the causes and the management. And you very well brought across what are the options we have for tocolysis, and also brought up the glory of isoxsuprine, which was the only drug we did have during our postgraduate days. And then, of course, we have come up to atosiban, but of course, atosiban is sometimes not in the reach of all our patients. But of course, nifedipine has made a revolutionary twist in the management of preterm labor. Along with, of course, we have the progesterones, we have the pessary, which is not used in our country, but of course we have the stitch, the cervical encerclage, as well as we have the
Bharti, you're muted.
Sorry. And we will move on to the next session. And I think Dr. Ramani ma'am has just said she has to chair a session in another webinar. She will just give the opening remarks, and she will be joining us back. So if the convener, Dr. Vidya Tobi, can start.
Yes.
We have the experts, Dr. Durgadas Asrana and Dr. Vidya Tobi as the experts. And we have our panelists.
I just will introduce our panelists.
Their CVs so that we can give a brief introduction of the experts as well as the panelists. Arun, could you please post the CVs? Dr. Durgadas, Dr. Arun, are you there?
No, Arun is not there. Where is Arun? We have to train him. Yes.
No, he's usually there. He's usually there.
I'm there, ma'am.
Yes, he's there. Yes. So I would like to welcome Dr. Durgadas Asranna and Dr. Vidya Tobi, who will be the experts for this panel on preterm management of preterm labor. And we all know that Dr. Durga, if there is Kasoga, there is Dr. Durgadas everywhere. He has been with
Yes.
Kasoga for numerous years, and of course, he is going to take the chair of the president in the next year. He's the president-elect 24-25. He's been the treasurer in 2022. Past EC member, and he is an eminent consultant in Tumkur, and he has his own hospital, Kasturba Hospital, and he also has a lot of academic institutions. Could I have the CV of the panelists, Arun? Dr. Kasturi ma'am, Dr. Rajesh, yes. We all know, all Kasogians are familiar with Dr. Kasturi ma'am. She's been the past president of Kasoga, and she's been the past HOD of KIMS Hubli, and the professor, ex-president of Hubli Dharwad Society, ex-secretary general, and she is a principal investigator in various international research projects. She's an MCI inspector. She's a UG and PG examiner in many universities, and the chairperson of graduate committee, a trainer of trainers, faculty at many state, national, and international conferences, an active Rotary member, and she is the one who conducts the Kasoga Jnana Harsha PGCME for the last 8 years, which is a real boon to the exam going postgraduates. And madam has also chaptered numerous chapters in many books and conducted many workshops, CMEs, and conferences. Then now we will have our own sitting secretary, Dr. Rupa Prakash is here. Dr. Rupa Prakash is a gold medal winner from Hubli, and true to that, she is a very good academician, very crisp in her talks. She has graduated from MMC with the DGO and MD. She's been the assistant professor at KMC Manipal. Later on, she was the head of the department at the JSS Medical College, Mysore. She's got numerous years of teaching experience as a PG, UG teacher, guide, and examiner. Right now, she's a consultant in Kamakshi and Apollo Hospital, Mysore, and she's been the president and secretary of Mysore OBGYN Society, and she is a faculty. Next, we have Dr. Rajeshri Palari.
So these are the different
secretary, the secretary of Karnataka State OG Association, and she's the dean of the research KBN University in Gulbarga. She's the member of the Academic Council, professor of Kalburgi University Department of OBG KBN NIMS, and she's a postgraduate and undergraduate examiner. Kindly mute the others. She's the director and consultant in OBG in Aditya Multi-Speciality Hospital.
Overall up nano ka total.
Arun, can you please mute those who are talking? And of course, her academics come from the gold medal she first got in OBG. And of course, she's the GSC team member in Rotary and represented India in the Australian team. She's been the organizing secretary of the Kasoga conference at Gulbarga and the past president of the Gulbarga OBGYN Society. Welcome, Dr. Rajeshri. Now we have Dr. Rajeshri Eliwal, who very successfully conducted the conference in Bijapur. Yes, and she has 18 years of experience. She's the professor and unit chief at BM Patil Medical College in Bijapur. She has presented numerous papers in international and national publications. She's a faculty for various regional, state, and international conferences. We received prizes for presentations in Kasoga in 2009, 16, and Yuva Foxy in 2004, and a Best Teacher Award. She is associated with the International Research in Rural Vijaypura. Delivered many public awareness talks on PPH and numerous other health issues. She's a reviewer of journals like the international journals IGAOG, IJWH, SBMC, and she's been the former secretary of Bijapur Society, state committee member of Bijapur, and the former vice president of IMA Bijapur, and the adolescent committee member of Kasoga committee. And then we have Dr. Sunita. She is the professor and unit chief in SDM College, Dharwad, and she has numerous publications and papers at state and national levels. First prize for her paper on GDM diagnosed with single test and its outcome at the Kasoga 2013 convention. She's an ICOG fellow, fellow in Minimal Access Surgeons of India, a life member of IAG. She served as the president of Hubli Dharwad Society and secretary of HDOH. She is the best volunteer by the Family Planning Association of India, Dharwad. She does honorary service at the FBI. She's interested in fetal medicine and high-risk obstetrics, and her special forte is difficult NDVH, TLH, lap myomectomy, and teaching. And now we have Dr. Shubha Ramrao, who is the immediate past president of BSOG and a senior consultant and head of department at St. Martha's, a DNB teacher, guide and examiner, a life member of BSOG Agoy and BMS, vice president BMS, and she's been faculty at national and international conference. So with this very exuberant and very enlightened panel, let us panelists, I would go ahead with the panel. Dr. Ramani Madam is the the moderator along with me. Madam will be joining us in a short while, but I acknowledge that the presentation I am going to present here was done by Dr. Ramani Madam, and she has indeed lessened my job, just like Dr. Vidya Thopi, who has helped me in convening this meeting. So with the permission of the chair, I will be presenting the presentation. Just give me a minute. Sure. Can you see my slides? Arun?
Yes, yes.
Yes,
Let's
yes.
start from the
Yes,
first.
we can.
Yeah, I'm going to go.
Make
I'm
it
going
full
to
screen.
Okay.
Make it.
So this preterm labor, Dr. Vidya Thopi has set the ball rolling, and she has already spoken to you about the nuances of preterm labor. And now let us have a case-to-case discussion about how we would tackle cases as they enter into as we see them in the clinical scenario. So I've already enumerated. So as you all know, I'm going to skip a few of the introduction slides for paucity of time, and as Dr. Vidya Thopi has already enumerated. So it's an onset of uterine contractions of adequate strength and frequency to cause progressive dilatation and effacement of the cervix before 36 weeks of gestation. So is Dr. Kasturi ma'am is there? And we know that preterm labor is very common.
No, madam.
And we should discuss the management. So let
Please
us see how
call
it is.
Kasturi.
So if any other panelist, either Dr. Rupa or Dr. Sunita, how often do you get to handle preterm labor in your practice? I think this can go to all the panelists.
Good evening, ma'am. It's quite
Yes,
common.
Yeah.
Only today, just now, I removed one cervical stitch just at 30
Okay.
weeks, and she had to deliver in spite of, we gave her atosiban. She prolonged for 5 days. Then today again, she had a bit of heavy bout of bleeding. Then I had to remove the stitch just before I came to attend this webinar.
So hope the
I
baby
think
is
we
doing
can't-
well.
It's quite common, ma'am.
So is the baby doing well?
Yeah, it cried, and it's around 1.2 kg shifted to an ICU, ma'am.
Yes.
We gave her MGSO4, we got time for all the interventions. So pulled on till 5 days, ma'am, from the time she got admitted. Sunday she got admitted, and today is Thursday. So all the things what we are going to discuss today, like tocolysis with atosiban, we did that. We gave neuroprotection, we gave steroids. We had put cerclage because she had prior preterm delivery 30 weeks. But that baby is doing fine, ma'am. I convinced her this time, because you have a very important risk factor for preterm, I'll go ahead and put a stitch, but then that didn't work. So I don't know.
Yeah,
I was preparing for this.
Yeah, that is the scenario in clinical practice, right? We put all our efforts
doesn't work
and
sometimes.
but
Yeah,
it does not work sometimes. But of course, the neuroprotection and the 5 to 6 days you pushed may definitely help with good NICU care. So I would say that, yes, as Dr. Rupa would say, it is quite common. We should say about 2 to 3%. But of course, I think in the private practice, it has considerably come down. But I think in the public sector, with the malnutrition, early marriages, repeated abortions, we still see a good number of women presenting to us in preterm labor. So
And if I can add, it also depends
madam.
on where you're practicing. You know, if you're set up as an NICU, you're naturally going to be dealing with many more patients of preterm labor, because you are geared up to, look after those preemie babies. And otherwise, you tend to, refer them to places which, if you cannot handle in your setup. But yes, the diagnosis, whatever prophylactic treatment that you can give, or if she has come as threatened preterm, then it is just very important to give her proper treatment before you refer her to any other center.
Yeah, very true. Thank you, Dr. Shubha, for that input. So, Dr. Rajeshri, how would you differentiate between threatened, diagnosed, and established preterm labor?
Good evening once again. Luckily, not all patients who present to us as preterm pains will end up in the true labor, and there would be threatened preterm labor, when there could be uterine contractions, that is the regular uterine contractions, but fortunately no cervical dilatation. So we call it as an established preterm labor only when there are regular uterine contractions with cervical changes. So cervical changes of more than 3 to 4 centimeters is definitely an established preterm labor. But to diagnose it as a preterm labor, we need to have the regular uterine contractions and with cervical changes. It could be either in the form of effacement or dilatation. But it is an established preterm labor once there is a cervical dilatation of 4 centimeters or more. So that's how it matters, because the intervention that we go on to do is judged based upon what phase of or how do we define this preterm labor as. If it is a threatened or diagnosed, then definitely the medical management would help. But if it is an established preterm labor, then the total management protocol will change.
Thank you, Dr. Rajeshri. Dr. Rupa, how would you classify preterm labor based on gestational age?
So now the definition is from 20 weeks to 37 completed weeks. 20 weeks onwards to 37 completed weeks. So it is extremely preterm when it is less than 28 weeks, early preterm when it is 28 to 32 weeks, and late preterm 32 to less than 37 weeks. And why they have classified like this is most patients we get between 32 and 37 weeks where the outcome is fairly all right if you have a good setup. And in any setup for that matter, if it is extreme preterm, less than 28 weeks, please don't give them good prognosis, because we really do not know. Baby may survive, but the long-term neurodevelopmental delays or the cerebral palsy, we may not know. So that is why we have classified like this: extreme preterm, early preterm, and late preterm.
Yeah, I think that's very clear. The point is well taken. And we should remember that preterm labor belongs to one of these fine painful P's that we obstetricians always have. That is PIH, prematurity, PPRM, and PPH, and preterm labor. These are the ones which give us sleepless nights and sometimes cause a lot of pain to us. So I think Dr. Shailaja...
Parturition should be added there.
Yeah, okay.
Parturition.
No, that I think we have accepted it when we became OBGYNs long back. That's one. So I welcome Dr. Ramani Madam back after jumping into another webinar. Madam is back. And this is the advantage of this digital media of Zoom and other platforms. Welcome, Madam. And I think Dr. Shailaja Madam is not there. Madam, please continue. Dr. Rajeshri Eliwal will be there in place of Dr. Shailaja. So Dr. Rajeshri Eliwal, what are the immediate problems faced by a baby born before term? And is this a relief to the mother that we have delivered and she's done with it? And is it a relief to the obstetrician also now that we have delivered her and just Sunita has handed over the baby to NICU and are we done with it now? Dr. Rajeshri ma'am, is she there? Dr. Rajeshri, are you there? If Dr. Rajeshri is not there, Dr. Shubha, Dr. Rupa can take the question. Yes.
Yeah, the thing is, we definitely have to prolong that pregnancy as much as possible before it becomes inevitable and we have to deliver. Either it's an inevitable preterm labor or for maternal condition that you may have to, have an iatrogenic premature baby. So the thing is, yes, there are so many early or short-term effects where the baby needs NICU care, may need the ventilator depending on the gestation and the lung development. And normally the NICU stay gets prolonged. Babies develop a lot of infections. Sometimes the NICU stay is so fulminant, they develop infections. Nowadays, though they start early feeding, the risk of necrotizing enterocolitis is very high. And with the baby in the NICU, there is no bonding. So, the mother is in distress and babies develop jaundice. And the most important thing is retinopathy and all, which are the later effects of the treatment that babies develop. And we don't know what the long-term neurological effects of the baby will be. And because of the retinopathy, we nowadays see so many of these preemie babies, as toddlers, they're wearing glasses because of problems in the NICU. And of course, immediate complications also intraventricular hemorrhage and because of NEC, GI bleedings, and so many complications can happen in the immediate neonatal period. May need, surfactant for treatment. And of course, for the mother, the distress of not handling the baby, lactation problems, definitely. And then, of course, the fear of losing the baby. All these are real and true for the mother too. And compounded to all this is, when you're looking at the financial burden of the treatment that is needed.
Yeah. So I think Dr. Shubha, thank you.
So for undergraduates, they should remember every system. Preterm baby has problem with every system. You start
Every
from
system.
CNS and then end in the lower end. So every system
Correct.
is premature. So every system will have a problem.
Shall I add one more thing?
Yes,
See,
madam, please.
Not only that, this preterm labor secondary to hypertensive disorders where this is associated IUGR, they suffer a lot. They are the candidates who are prone for future onset of early onset of diabetes, hypertension, renal disease, and etc. So we should not be happy that the baby with preterm and hypertensive disorders, maybe they may not have RDS, but they have all the other complications.
Yes,
so
it is.
That is one important point. And another thing is the psychological impact for the mother. Postpartum depression is found to be very high among the preterm mothers who deliver preterm.
Yes.
So they don't expect that, and they are not able to handle the babies. And as you rightly pointed out, the fear of losing the baby is there. Yeah.
And the problem is compounded when the prematurity is due to a multiple pregnancy.
Yes.
It's a double whammy.
Double trouble.
Yeah, double trouble actually. So everything gets compounded there, and it is a real distressing situation.
So
and everything depends on how premature is the prematurity.
Yes. Thank you, Dr.
The weight
Shubha.
of the baby, IUGR, of course, the Barker's hypothesis holds so true. Nowadays, we're trying to save this 26, 27 week babies, depending on their Doppler studies, and we really don't know what we are doing to the future of those babies because
whether we are correct in saving these babies. I think beyond 32 weeks, we are justified. But below that, 26 to 32 weeks, we should be very careful. Because the parents, they spend so much, the stress they undergo, and ultimately we give up the baby who has got some long-term complications.
Yes, developmental changes.
Yeah. It is very distressing to see some mothers, carrying these babies. And they are so, I mean, a situation is very sad. I sometimes wonder, are we trying to play God by, saving these 500, 600 gram babies? So we really need to think a lot before, we do, of course. The thing of saving every life, all those things, so many questions arise.
Very true. Thank you, Dr. Shubha. Dr. Ramani, madam, you can take the next, please.
Yeah, I will start with the case reports.
Case discussion. So we all reports. So I think we will go to the case reports because all this has been already discussed.
Yeah, so, and Dr. Vidya has very beautifully covered the entire thing. Entire thing she has covered. I think we'll go to the case reports.
Yes, madam, please.
Yeah. So this is a 26-year-old primary gravida. 3 months of pregnancy, she came for the routine checkup. Family history is not significant. Normal BMI, normotensive, basic blood work normal, dating scan done at 8 to 9 weeks, single intrauterine fetus. At 13 weeks, she comes for her NT scan. And the CRL corresponds to 12 to 13 weeks. Her NT, nasal bone, everything normal. Cervical length is 3 centimeters. Adnexia is normal. She is supported with folic acid, iron, and calcium. Is she a potential candidate for preterm labor? That is looking at 3 centimeter length of cervix. Is it going to bring you something that we have to follow the patients very carefully? This question goes to next.
Dr. Rupa.
Yeah.
Yeah, actually,
Rupa?
this patient, can you hear me?
Yes, very well.
This patient is a very low risk patient for preterm labor. She's a young preemie and no other risk factor. So she's very low risk for this thing, 3 centimeter. And actually, according to books, we are supposed to look at the cervical length in a low risk patient only after, during anomaly scan.
Yes.
But whenever it is 3 centimeter in early pregnancy, there is nothing wrong in, just reminding her that there is a possibility that her cervix may yield. And so she needs to be little more careful than other primigravida.
Yeah, so you are rightly said that we have to sound the patient that
Yeah.
she may have a preterm labor, and we can
Yes.
evaluate what are the other factors which are preventable causes or modifiable causes. For example,
Yes,
like if
yes.
she is having a vaginal discharge or chances of
Discharge.
bacterial vaginosis, all these simple things we can, or urinary tract infection, all those things we
Yes,
can.
yes.
Then would you like to, this is how we should go for counseling. So
Yeah.
treat urinary, vaginal or gingival infection and look for bacterial vaginosis and if it is. Dr.
Asymptomatic
Shailja, would you
bacteriuria
advise-
is one which we have
Pardon?
to.
Yes,
Yeah.
Asymptomatic bacteriuria.
Yeah, that
Yes,
is
very
very, very important
important.
because asymptomatic
Yes.
bacteria is one important cause for preterm labor.
Yeah.
Dr. Shailaja, would you advise this patient that
Madam,
having...
Sorry, madam. Dr.
Yeah.
Shailaja is not there, madam.
Yeah,
You can
whoever
ask
is there can take it.
Yeah,
Dr.
in,
Rajeshri.
Dr. Rajeshri Eliwal is
Rajeshri,
there.
then you can take it. See, having seen that there is a reduction in the length of the cervix, would you advise the patient bed rest, or would you give her prophylactic progesterone, or would you like to go for a cervical massage at this stage, or all of the above, or none of the above? What you're going to do?
I think we can ask all the panelists this question.
Yeah.
Yes, Dr. Rajeshri. Dr. Rajeshri Eliwal is not there. Dr. Sunita?
I think we 20 weeks. I think we less shots of go ahead and cervical circulation. To give estrogen, absolute bed rest I wouldn't recommend. Adequate rest without avoiding prolonged standing should be fine, ma'am. And treat the infections. Look for bacterial vaginosis, other infections in the body. That should help her.
Would you like to tell the patient that she should refrain from sexual intercourse?
Yeah, of course. Yes.
Of course.
Because
Refrain.
you know that prostaglandins in the seminal fluid can trigger
Yes.
preterm contraction. Okay, then what about prophylactic progesterone?
Progesterone.
Dr. Rupa, would you like to put this patient
Nothing wrong, but now most often we come across women who are working. My main problem is whether we need to ask them to abstain from their work and be at home, or ask them to continue working with this scenario.
Yeah, that's a very important point we have to
Because
discuss.
80% women are working now.
Yeah, that's but probably what I would say is people who are working with not doing
Physical
anything.
activity. Lot of physical
activity. If it is not too
strenuous
much,
activities.
then maybe we can allow them.
Yes.
The restricted thing, we have to tell them what are the signs and symptoms of progressiveness of this preterm labor, and then we have to tell. I think there is no harm in putting prophylactic progesterone for this group of women who are working. And
In
cervical
this,
clutch,
the cervix
Madam?
is 3 centimeters, no, madam?
no, 2.5. It has come
2.5.
down.
Okay,
from 3 to
2.5.
2.5.
Yeah, then I would definitely, prescribe vaginal progesterone, 200
Yes,
milligrams
agreed.
daily.
Rupa.
And of course, warn her about everything. If she's working from home, good for her. If not, I'll ask her to, avoid two-wheelers and go in a four-wheeler.
Bumpy roads.
Yeah.
Roads.
Avoid bumpy roads. Avoid, of course, definitely avoid sexual intercourse, and try to take adequate rest even in her office, where she doesn't have to lie down, but at least she can recline and rest. So, and then of course, call her for regular checkups, screen her for vaginal infections and asymptomatic bacteriuria, and see how it progresses.
Then would you want
madam,
to do a
I
cervical
say one thing?
screening in each
Yeah,
visit?
actually, years back, in fact, when I was a student, I was told that put a cervical cerclage because she's a working woman. It is going to help her. So I'm not 100% sure, but I think I may put a cervical cerclage.
See, sometimes
Madam,
it
can
may be
I
adverse to
add-
the patient.
Madam, I
Putting
would like to
cervical
add.
cerclage in unnecessarily, that can also trigger preterm
Yes.
labor.
Yes, yes,
So
that is
only
after
in
explaining
indicated
everything.
cases, whether
After
it is
counseling.
indicated by the previous history or reduction in the length of the cervix, or with the only these are the certain indications.
Yes.
We have to go for it in cerclage. Otherwise, I think we need not go. Next
If
slide.
there
Madam,
is,
I would like
if
to
there
add
is
here.
funneling at the
Yeah.
internal os, then we can, definitely we should go ahead and we have to do the dynamic ultrasound, and if there is
Yeah.
funneling, definitely we have to do the cervical encerclage.
So
Ma'am,
the
along with
important
this,
point what I gained from you, Subha, is the person who does the ultrasound should do it properly. Because
correct.
sometimes if you
The
don't give
funneling.
a gentle pressure, it will appear
Yes.
normal, internal os will be given, appears closed. But if you give a pressure,
The
maybe
funneling.
it starts funneling. So that the person who does the procedure should be quite confident regarding the diagnosis of it.
And
Madam,
this-
one
We
more
should
thing.
always request for TVS, not
Yes,
transeptal. We
yes,
should always request for TVS.
So, and madam, one more thing is along with prophylactic progesterone, in these early preterm, threatened preterm, I do put them on a course of probiotics. And we have
Yes.
seen them improving
100% I agree.
probiotics.
Probiotics definitely prevents
Put them
preterm
on
labor.
that. Yes,
So
madam. That's what
bacterial
we need to do.
vaginosis is reduced and the incident, the percentage of this healthy lactobacillus is increased. So that will prevent the formation of this prostaglandins and all the other
Yes.
chemicals that are produced by the bacteria.
Yes,
So
ma'am.
2 weeks of
Madam,
probiotics.
in this
definitely-
case, in this case, only cervix is shortened.
Yes.
Can we call it as preterm labor, threatened preterm
No.
labor?
No, she doesn't have symptoms. She doesn't have pain.
No contractions.
Yes.
No
No
contractions.
contractions, yes.
But
Okay.
I believe, ma'am, between 16 to 24 weeks, the cervical length generally doesn't shorten. Only
Yes, yes.
patients who are going to become preterm will reduce. So probably it's a very
Yes.
important hint if it's done properly, done by
Yeah.
a good, following all the guidelines. I think if it's a
See,
shorten,
one thing
worth
is
going ahead with the
trans-abdominal
stitch.
scan is not so reliable. So either it
that
has
is
to be
important.
TPS or a transperineal at least. Because
Yeah.
sometimes the patients are hesitant about a
Hesitant to do it.
transvaginal scan, especially if they have had previous problems or have become pregnant with treatment and all that. Then they attribute that TVS for so many problems. So you can
Madam, in
Rupa.
practice,
Please go ahead.
in practice, D and C is very important. D for documentation and C for counseling.
Counseling.
See,
Yes.
because these are the patients we don't know. We
Tomorrow.
don't know whether they will really get into preterm labor, and retrospectively we cannot do anything. So you counsel them that there is a possibility. Taking rest, taking progesterone, doing the cerclage, you offer them. And if they don't agree, then document and counsel them.
And
So the
always
message
counsel the
is-
family also. The
Yeah,
family.
I feel
Counsel the family.
counseling the family or the spouse is more important
Yeah, because they
than
don't
telling
want
the
help.
patient herself. Because if you
Yes.
tell the patient she's under stress, of course, in general, we can tell her for all these symptoms you come, but we need not tell her you're going to deliver preterm.
Yeah.
Tell that husband that possibility.
Husband, the
is
family
there.
has to be counseled.
Yeah, family
Yeah,
has
very
to be
important.
counseled.
So the
Mother-in-law.
ultimate message is every pregnancy is potential for preterm labor.
Yes.
We should be aware. See, we have seen
Yes.
patients coming just 1 week back with a healthy pregnancy with a normal cervix, but suddenly they will come out, and especially it is scary to see this ART conception.
Yes.
They land up with that.
Yes, ma'am, yes.
Invariably,
yes.
they are the ART pregnancy.
Very,
they
very
land up.
correct.
Oh,
Yes.
okay. Then moving on to case number 2, Dr. Bharti, you can take this.
Yes. So there's Mrs.
So,
L.
ma'am, just a minute, ma'am, a clarification.
Sunita.
So,
Yes,
Ramani,
Sunita.
ma'am, you don't agree to put a stitch, ma'am, in this patient?
No, I would not.
I think
No.
there is no
Madam.
indication for stitch in this patient.
Yes, Dr.
unless the
Durga,
length
that's-
is too much low. That is less than 2.5 centimeters. We
Madam.
have to keep watching. Give
Can I step
progesterone.
in here?
So,
Madam, can I
encephalus
intervene
is
here?
not indicated in women who have not had a previous spontaneous conception, or presently in this current pregnancy, the length of the cervix is less than 2.5 centimeters.
Yes, sir. Dr. Durga
In
Das,
fact,
our
less than
expert.
1.5 is the critical length for a cerclage, no,
Yes.
madam.
1.5.
Less than 1.5. 1.5 to 2.5, they say all this progesterone and all the
Great,
other
yeah.
things.
Great.
And
Durga Das, please go ahead.
yeah.
Yes.
Dr. Durga Das, your
With respect
input,
to
please.
rest, bed rest is not advised. Of course,
Yes.
no jerky movements. Especially try to avoid night duties. It has been seen that
Yes.
any girl working beyond 8 hours a day or in the night duties, they are prone for high risk for preterm labor. Coming to the length of the cervix and the gestation age, 2.5 centimeters at 24 weeks, around, yes, you advise vaginal progesterone, repeat PBS once in 2 weeks.
Yeah,
If
that
the
is what I
length is
do.
redu- If the length is reducing, of course, 1.5 is the cutoff point, but don't wait up to the 1.5. If the length of the cervix is reducing, that is the indication for the cervical stitch.
Cervical stitch.
If not, there is no
Fully
need
agreed,
need
sir.
of cervical stitch. Continue vaginal mechanized progesterone up to 36 weeks.
Yes, thank you, sir.
Agreed,
And
fully.
give them the rescue antenatal prophylaxis also at around 28 to 30 weeks if she's continued that.
Yes.
Yes.
Of steroids. So now we go to the second case. Mrs. L, 38 years, booked primi gravida, came for routine ANC and growth scan at 30 weeks. Her growth scan, everything was normal, appropriate for gestational age. The cervix was 2.3 centimeters in length and the cervical dilatation was around 2 centimeters. The cervical length during NT scan was 3.2 centimeters. And now at 30 weeks, she is 2 centimeters. So Dr. Shubha, what would you like to do for this lady?
Yeah, definitely. I'm a little worried for her because she's elderly. She's 38 years old, and she has had this, silent cervical dilatation and shortening of the cervix definitely is there. So if she was not already on at this stage, yes, I'm going to warn her. And I would like to put her on vaginal progesterone and do a cervical cerclage because of her history and all that, I would want to give her the best chance. Definitely there's shortening and there's dilatation. So progesterones and cerclage is what I will plan.
Yes,
And
Dr.
of course,
Shubha.
prophylactic.
We did the stitch, we put her on progesterone as you said, and we followed your advice and gave her steroids. But unfortunately, she started leaking and she had bleeding PV. So what are we going to do now?
Now, if I have not, as you said, you have already given the steroids, but I would like to give her Maxelf also because, she's under 32 weeks now. And I'm not too worried because appropriate for gestational age. So I expect the baby to be at least 1.7, 1.8 kgs. And so I would give Maxelf and then wait and watch. Of course, having done a vaginal swab, ruled out vaginal infection, and if whatever appropriate antibiotics I will give her and try to find out the cause for bleeding. Was it because of the cervical stitch itself or is there any abruption? That is what I have to rule out. And because if there's any abruption, then I remove the stitch depending on whether it is vertex, and if she goes into spontaneous labor, I'll allow her to deliver. Otherwise, I'll have to decide on the mode of delivery for her. But I would like time. If it is abruption, of course, I am not going to wait. But otherwise, I'll bide time and put her on Maxelf, give her steroids if not already given, and then plan delivery.
Ma'am, I have a clarification. What is the gestation age upper limit for rescue cerclage?
See, even a
It depends.
single day of
Will give
that is going to give a better outcome. So this was the patient done by me at 30 weeks. Maximum was this patient. I have done an encerclage, rescue encerclage for so many of my patients. We were able to get 70% live babies, which of course needed a NICU care. So this particular patient, even that 1 week time that had given me, that baby was all right. So for one of my patients, actually what I did was, I did an encerclage. Then one day, I thought when she came for the review after a week's time, it was just one lip was cut off. So what I did was, I removed the stitch and I put in the Arabin pessary. Arabin pessary is excellent. So I thought, it is being a non-invasive one, I thought I can go in for an Arabin pessary. And to my surprise, after a week's time, when I took her to theatre and when I saw, the cervix was again very well formed. So I re-stitched it and I took her to 37 weeks. So there are situations where we have to act according to the case scenarios, maybe a combination. Like cerclage with Arabin pessary or put in Arabin pessary followed by cerclage, whatever is feasible that we have to go in. So even this patient.
But when membranes are bulging, like I could see in the photograph there, it is very, very difficult to put a cerclage, and the chances of rupture of membranes is very high.
Yes, that we have to tell the patient before taking the patient for suturing. But fortunately, so far I would have done more than 10 or 12 cases. I had ruptured membranes only in one patient. So this, what I do is, I just use the Prolene, do it like a tacking. So at the lower level, I put the stitch, then again one above the previous one. So this is the last picture. You can see there are 2 layers of stitch what I have done with the Prolene.
And you can give a deep
even if
Trendelenburg
patient
and
doesn't
sometimes
Deep Trendelenburg.
from Foley's
yeah, deep
catheter.
Trendelenburg.
Police
Police
catheter.
catheter. That's what we do. So Foley's
Yeah,
catheter gently
It all
push.
depends. I tried with
Yeah.
police, but I found that this technique is comfortable for
But
me.
deep Trendelenburg first, if that is enough.
Yes, I
see,
always put
Yeah.
them in the deep Trendelenburg.
if that
See,
is
deep
not sufficient.
Trendelenburg and tocolysis is very important
Yes.
before attempting this, because
Yes, yes.
we never know, you know, the moment you put her, there will be a mild
Movement.
contraction and the membranes will start herniating more. So
Yeah, that's very important.
tocolysis, even if you have, patient is not complaining of pain, deep Trendelenburg, and then I wouldn't rush her to the OT in 2 hours.
Yeah, you
I
can
will
take your
give
time.
her a little time to relax and then take her to OT.
Yes.
Vaginal swab, vaginal tablets,
Yes,
betadine
yeah.
tablet, and then probiotics. They are a must before putting the stitch.
Yes, ma'am.
Okay.
So the rescue cerclage, as Madam has told, up to I think 32 weeks should be, because beyond 32 weeks, I don't think we would do in the modern, the outcome will be quite good with just steroids and magnesium and postponing the delivery with good NICU facilities. So now, Madam, the next case. So in which conditions? I think this was what conditions in which encirclage should be done, Dr. Sunita?
Yeah, as we have been discussing this,
Yeah.
history-wise, if she had a painless abortion in less than 24 weeks, or she had a preterm delivery, strong evidence of preterm delivery with the previous pregnancy, we would go for that. And of course, as we discussed, cervical length shortening on ultrasound, less than 2.5 centimeter, less than 24 weeks, probably that will help. Then physical examination, yes, I mean, not that accurate. So depending on the history and cervical length measurement, go for cervical prophylactic cervical length.
And history, the other one is frequency of micturition and chronic lower abdominal pain. Sometimes we tend to cursorily just dismiss that as a normal symptom of pregnancy. I think we have to be on the lookout for that also.
And on PV, if there is softening of a previously very firm cervix, may indicate
That
that, you
also
know,
gives a
cervical
clue.
changes are happening and that she may go into preterm labor.
Yes.
Yeah. So Dr. Sunita has very well brought about this. History indicated cerclage. Ideally, you would do it at 12 to 14 weeks after confirmation of pregnancy viability and any major anomalies. And of course, ultrasound indicated cerclage is like the serial ultrasound. There's a shortening of the cervix, so it could be an emergency or it could also be an elective procedure. So the role of steroids, Dr. Kasturi Madam is not there. Dr. Rajeshri, could you kindly enumerate the role of steroids, which is very important? Any number of times we have discussed. Yes.
Definitely, it's way beyond doubt now that steroids are established beneficial value for the management of preterm birth. What started as an experiment in sheep in New Zealand now became applicable and so widely used, and such a miraculous drug that such a cheap drug is going to save millions of dollars or rupees in terms of NICU admissions. So the steroids used are betamethasone or dexamethasone between 24 to 34 weeks of gestation, beyond doubt. Between 34 to 37, yes, it may improve the respiratory status in the form of decreased neonatal morbidity and NICU admission. So by and large, 24 weeks to 37 weeks would be ideal scenario wherein we can use betamethasone or dexamethasone. And betamethasone, 12 milligrams, 24 hours apart as the propionate salt, and dexamethasone, 6 milligram, 12 hourly 4 doses, preferred in patients with diabetes and pregnancy-induced hypertension, because the other drugs, the betamethasone, may slightly increase the level of blood sugar levels, and thereby when the patient is on medications like insulin, etc., when betamethasone is given, slightly there should be a modulation of the dosage, and this has to be counseled to the patient that do not panic, and slight increase will help to modulate, which will pass over 2-3 days of time. Otherwise, DEXA would be preferred, and this has to be given as a 2-dose, and suppose the patient goes into labor, even after giving the dose of the steroid, like say 2 weeks later, then we can resort to what is known as the rescue. The rescue medication, wherein a single dose is beneficial, and this helps in preventing the complications, the respiratory distress, etc.
Thank you, Dr. Rajeshri. And I think
Yes.
here the one point to be taken across that if you don't have the propionate salt, because generally we have the betamethasone phosphate salts, I think then it would be more judicious to use the dexamethasone. I know, but it is a little inconvenient because they have to come 12th hour for 4 doses. So probably we'll have to keep them as an inpatient or make arrangements for the same, either the home delivery of the system. I think this is
Dr. Bharati, I would like to add one more thing.
Yes,
See,
madam.
in patients with diabetes, especially on insulin, I would always prefer them to get admitted.
Yes,
because
madam.
that definitely the
Spike is there.
are going to rise, and she may need 4 to 6 units higher than what she was using. And the chances for her to come back to normal takes even 24 to 48 hours after you stop the second dose.
Yes.
So I always prefer them to get admitted. And then rescue dose is always 1 dose.
Yes,
See,
1
even
dose.
now the pediatricians are telling, even if you post the patient for elective C-section at 37 weeks,
Yeah, give
a
one.
single
Give
rescue
1 dose.
Yeah. Previously, what
Another,
39 weeks.
pardon?
Another problem with
Especially with
steroid
GDM
is
and
that,
all, up to 39 weeks, you have to give steroids.
yeah,
Yes,
And suppose I'm giving steroid, I mean, practically, if I'm giving steroid to a lady who is not GDM, then what I would do is I would admit her after the second dose, because normally first dose will not raise her sugars. At least 1 day stay in the hospital becomes less. So
You are
I will
absolutely
give her the
correct.
injection. I'll next day I ask her to do a fasting or whatever at home and then come back and then give her the second one and then admit her.
Yes, yes, Dr. Rupa.
another problem with the steroid administration is patient most often complains of reduced fetal movement.
Yes.
That is why I always admit them. Because they're really concerned with the reduced fetal movement. So at least in hospital, we can reassure them and monitor them more frequently.
Yes. It is more prudent to admit them and be safe for them as well as for us.
Correct.
Okay, next slide.
Yes, next, madam. So yes, this is the
I
cortex.
think we have discussed all these things.
We have discussed this. So the same patient then came with draining and spotting PV. The USG done showed an AFI of 7.1 centimeters. There is no active draining. So hence she was kept under observation. Prophylactic antibiotics were given. And then on 21/2, the patient had draining, hence the stitch was removed. She progressed on her own and delivered after 6 hours a baby girl weighing 1.8 kg, which was shifted to the NICU. So, Dr. Shubha, I think Dr. Sunita, one of you can discuss what is the role of antibiotics in such women who come with either whether you put the stitch or whether they come with a rupture of membranes. What is the role of antibiotics and how would you decide?
See, I mean, practically, unless the vaginal swab or, the blood tests are showing any evidence of infection, we are routinely not giving antibiotics. Otherwise, erythromycin is the drug that we give many a times. If we suspect some kind of a discharge and all, because for the report, the culture reports to come, this vaginal swab, it takes at least 48 hours to know what it is. So then we start the prophylactic erythromycin and then change over to appropriate antibiotic if the culture tells us that, there is some infection. But otherwise, routinely, we are not giving antibiotics without evidence of any infection. So if she has UTI also, I would start her on some infection. Antibiotics.
Dr. Shubha, for evidence, what would you do? A CRP and a total count or what? Or the only the
CRP, total count and a vaginal swab. Sometimes a gram staining also. If I'm suspecting a trichomonal, sometimes, this leak or looks like that little greenish kind of a discharge. So do a wet swab also. So look for trichomonas because then you're going to give appropriate drugs or chemotherapeutic agents, metrogel or tenodazole, if we suspect that kind of an infection. So, and if it is smelly, anaerobic infection, metrogel is what we have to add.
Any other inputs from Dr. Sunita, Dr. Rupa, and Dr. Rajeshri?
Yeah, exactly agree with madam. We send for high vaginal swab, urine culture, we do a total count as well as CRP. And then if there is asymptomatic white discharge or UTI, we'll give them azithromycin and onidazole, 500 mg BD, azithromycin 500 mg OD for 5 days, and wait for the culture report and then act accordingly to the report.
And one more thing, tell your staff.
Ruptured membrane, no waiting.
Tell your staff not to do unindicated pelvic examination. Very important, because otherwise they will, every time the patient says pain, they will be going and doing a pelvic examination.
Yes.
And no co-amoxiclav should be given.
Yes, no,
That's
yes, that should not be
important
given.
message. Okay.
Yes.
Next slide.
So that is what. Should antepartum prophylaxis be offered routinely? No, all of you, I think, have told routine prophylaxis is not required.
Not
Okay.
required. On
Yes.
the Oracle study and all,
Yeah.
does not advocate antibiotics at all.
Routine prophylaxis is
correct.
not required. So, Dr. Rupa, what's the role of magnesium sulfate in preterm labor?
So it's proved beyond doubt that Maxel helps for neuroprotection. And this is specially indicated in a woman who has hypertension, imminent eclampsia. It plays a double role there because there anyway you are giving Maxel, it helps for this also. So it acts by inhibiting myometrial contraction, and it is definitely recommended, especially when it is less than 30 weeks and when we have to deliver them. So antibiotic question mark, but steroid and Maxel, a definite yes.
Yeah.
And the dose is almost same like imminent eclampsia or eclampsia, where we follow the Zuspans regime. 4 gram IV loading dose over 20 minutes, followed by 1 gram per hour for 24 hours, or till the delivery, whichever is earlier. And like in any Maxel, RRR has to be monitored, no? Renal function, that is urinary output, reflexes, and respiratory rate. And the change is that cord clamping, earlier we used to say that immediately you have to clamp. One of the indication to clamp the cord immediately was this, because it puts a load on the fetal cardia. But now they claim that delayed cord clamping from 30 seconds to a maximum of 3 minutes is better for the preterm labor.
Thank you, Dr. Rupa. Yes, madam, please.
Let us move on to the case scenario 3. Here it is a 35-year-old G2P1 live one with 31 weeks of amenorrhea, presents with a backache, pelvic pressure, and menstrual-like pain since 4 hours. She denies any bleeding or vaginal discharge. In her first pregnancy, she went into labor at 32 weeks. Tocolitis did not help her, and she had a C-section for breech. Next. From this woman's history, do you think what are all the risk factors for preterm labor? You can pick
Yeah,
up.
she has all the risk factors, ma'am. She's
Yes.
elderly. She has got previous history of preterm.
And like symptoms suggestive of
Symptoms
preterm.
also.
And symptoms. And symptoms.
Symptoms also she has.
Yeah.
So she has a past history and she has the present clinical features.
So,
And one thing I just wanted to add was, this treatment for constipation, because most women are constipated and they strain at stool. So especially if you have had threatened preterm labor and she gives history of constipation, you have to give her some stool softener so that,
Yes.
she doesn't strain at her stools.
Yeah.
So history and the clinical. So on examination. Yes, madam.
General physical examination was normal, contractions 1 per 10 minutes, 25 to 30 seconds. And Dr. Subha, what would you do as a next step? Do you go for a speculum examination?
Yeah, definitely. I would do a speculum examination first to look for any discharge, any obvious dilatation of the cervix, any, membranes herniating or anything like that. And if I find that there's nothing and the os is tightly closed, after having collected a swab, then I might do gentle examination only at the pharyngeal examination. I will not put a finger into the cervix. I will just do a pharyngeal examination to look at the length of the infravaginal cervix. And of course, depending on, look at the consistency also. If it's a very soft cervix, then I know that some changes are taking place. And the position, if it is posterior, it is reassuring than if it has become mid-pose or if it has come anterior under the symphysis, then maybe she is going into preterm labor. And of course, depending on when she has had a last ultrasound examination, I will do an ultrasound examination. One thing is, in any threatened labor, we have to rule out anomalies, because there can be some late onset anomalies. At 20 weeks can may be normal, but at 26 weeks or something, 30 weeks, you may find little hydramnios and maybe hiatus, a hernia, diaphragmatic hernia, and some evolving anomalies which can be ruled out and therefore good for counseling. And then take forward, look at the cervical length also, and then take forward whatever has to be done.
See, can you find out the resilience of the cervix by doing an ultrasound? See, we have a special app that is to do elastography.
Elastography.
Shows yeah, the resistance is low. So
Mm.
that means the cervix is very soft
Yeah.
and it is likely to proceed for preterm labor. See, like you have rightly pointed out that there are certain anomalies which are picked up only in the late stage. An example is microcephaly. See, we have had cases of microcephaly, the same mother having 3 babies. So every time she goes up to 32 weeks, everybody says normal. But after 32 weeks, when she has a scan, it shows microcephaly. Nothing can be done for that. So this patient's speculum examination was
And
done.
if we are in an ideal setup where I can do a fetal fibronectin, then I
Yes,
would.
that we are coming. We are coming.
Yeah, we
So
go
the
with that.
digital examination is 50% cervix base, 2 centimeters dilated, and head at a -2 station. Next. So how do you manage? You want to
Obviously, she's going into labor. She's having contractions also, and there is cervical dilatation, shortening of the cervix. I don't know whether
2
effacement.
centimeters. It says 50%
Yeah.
that means 2
So
centimeters.
definitely she needs
dilatation.
admission, hydration. She needs tocolysis and if appropriate antibiotics if necessary. And then she is 30 weeks. So I would like to give her steroids. And if there is, of course, the rescue cerclage, if I will have to look at the pros and cons and then put a rescue cerclage, put her on some progesterones also. And then appropriately, if I think she's gone into labor, not responding to my treatment, then I would also give her Maxelf, because either nifedipine or magnesium sulfate. One of Maxelf will be my first choice because it will be neuroprotective effect also. And then give her some, reassess her after 4 hours, 6 hours, and then see what is happening. Unless she goes into rapid the labor and
Scripted labor, yeah. See, one thing is you have rightly pointed out that you should not combine nifedipine with magnesium sulfate.
Both.
Yeah, that is both you should not use together. Okay, next slide.
Dr. Sunita.
No.
Yeah.
Does tocolysis prevent preterm birth?
Not exactly, ma'am. It may not always.
Yes, not
At
always.
least it will give some time for the neuroprotective effect and the steroid effect. Maybe pull on
That's
for
all.
some
And
few
for
hours or
in-utero
few days.
transfer.
Transfer.
That's all. Next. So how long? See, one more complication I wanted to tell you. Suppose I've seen patients who are put on long-term tocolytics, especially this ART conceptions. Are they good or are they going to cause any serious effect to the mother?
Hepatic abnormalities.
Not only hepatic, it causes peripartum cardiomyopathy.
Yes.
There is a risk factor for peripartum cardiomyopathy. So better you do not use tocolytics for a very long time. Yes. And if it is going to be, you want to use a tocolytic for a short term. See, unless till the contraction stop and the labor doesn't progress, that is the time duration which we can use tocolytis. After that, we have to shift to only progestin. What is the best tocolytic? What you think? Next slide, please.
Anybody, Dr.
There is no best drug as yet, because each drug has its own advantage and disadvantage. Yes. But earlier we always used to use only isoxaprine, and it has made a comeback. But in affordable patients, atosiban is supposed to be the best. But nowadays,
atosiban can never prolong the labor beyond 1 week.
Yes. In fact,
that is also we have to see what is spending thousands.
I have never used atosiban, but I have had patients of ART pregnancies who were having contractions, and the ART specialists have put them on atosiban. But after 2 doses also, they have come fully dilated to our hospital for NICU care. Yes. So somehow I feel it is all too much of expense, and according to me, it has not really helped.
Yeah. Can I say something?
Yes.
Madam, atosiban for a short term, like especially when we want to have the benefit of having the advantage of the lung maturity and magnesium sulfate, definitely it has given a much benefit because we have had some patients very high risk and very like ART pregnancies and precious pregnancies, wherein the other drugs have failed to bring about the relaxation of the uterus, and atosiban has gotten great beneficial effect. So considering the fact that the risk-benefit ratio, there's no harm in trying atosiban when other drugs fail, is what I feel.
Yeah,
But we have to be definitely cautious about using the combination drugs, especially like Dr. Ramani mentioned about the cardiac effects and the failure which it can cause in peripartum cardiomyopathy, a serious complication, and sometimes even respiratory distress when we use the combination of certain drugs. So we have to be very vigilant about using the tocolytics as well, and each of the drug have their own role play.
Then again, combination of isosuprin with steroid, that's a very bad combination.
Yes.
We
Increase the
can't
sugar
Pulmonary edema.
Yes.
pulmonary edema. And one more thing is, you do not use isosuprin unless you rule out abruptio placenta.
Placenta.
Yeah, that
Correct.
is very important, because if you are
Got
going to use isosuprin when the patient is having early
That's
abruption
right.
presenting in the form of preterm labor, you are going to aggravate that, and the patient is going to go for a full abruption. So
Abruption.
that we have to be very careful.
And also in the
if
presence
she's
of
having
hypertension.
tachycardia, if the patient
Hypertension
is
and
having tachycardia, I
Yes.
don't think we must start that way. But most of the
Isosuprin.
tocolytics other than Maxelf cause tachycardia in the patient.
Yes.
Atosiban also
DKP,
doesn't cause tachycardia.
Isoxaprine, Ritodrine, all of them cause tachycardia.
Tachycardia.
But atosiban doesn't
Madam,
cause, ma'am.
nifedipine,
Doesn't
one of the worst problem with nifedipine is headache.
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 So they have persistent headache, very difficult. They have no pain, but they have headache. So it's a very difficult
And
situation
it becomes
to
worrying if a
manage.
patient is of PIH again.
Yes,
Yes.
yes.
And headache becomes
yes.
worrying.
Worry,
Yes.
yes.
So after giving a course of steroids, the pregnancy continues and she gets into labor after 11 days. Would you, anyone of you like to repeat the steroids? I think we have done it
Yes.
already.
We have discussed
We
this.
can repeat a single shot.
And-
So next
Yes.
is
Single
prediction.
shot after 2 weeks.
But if she's 34, 35 weeks, I don't
Not
think I
needed.
might.
Not needed. Yeah, if
no,
she's
no
above
need.
34 weeks, it's not needed.
No need.
So how do we
Okay.
predict preterm labor?
Prediction is current screening tests for prediction of preterm labor is risk factor assessment, then cervical assessment, then comes the biochemical markers. See, we have been routinely doing all this clinical assessment and ultrasound. Now, what are the newer biochemical markers which may be of use in predicting preterm labor? Dr. Rupa, next.
Yeah, if we consider fetal fibronectin as a new one, that's the best. But
Yeah.
it is little expensive and, but it's easy. Actually, it is done by ELISA method qualitatively. Qualitatively
But,
by ELISA method.
it
It's
takes
just like
48
doing a
hours.
pregnancy test.
But it
No,
takes
it's just like
dipstick
ELISA
test
method.
immediately it can.
It can. So it is exactly like doing a pregnancy test.
test.
Immediately
Okay.
we have the report. But if you want a quantitative assay, then it takes about 48
48
hours. It is
hours.
not
It takes-
available everywhere. It's not available everywhere. It is expensive. You need to get the kit, and you need to take the sample very correctly.
Yeah.
There should be
Yes,
no
that's the
blood or pus or any other thing except the vaginal secretion. So fetal fibronectin is always present before 22 weeks. Only between 22 weeks and 34 weeks, it is a
30 weeks.
reliable test. And it is something like a glue between the chorion and the decidua. So it just indicates that the chorion is getting separated from decidua, and that's why there is fibronectin in the vaginal secretion. So if it is available, that is one of the marker. But you have another marker. The test name is actin partus. It is phosphorylated insulin-like growth factor. Yeah, insulin-like growth factor. But all these have a good negative predictive value more than a positive predictive value. That is, if it is negative, then the chances of delivering in another 7 days is very less. But if it is positive, along with ultrasound findings of cervical length and dilatation of internal loss, then it gives a better result.
Thank you, Dr.
Next slide, please. Next
Yes.
slide. So how would you prevent preterm labor? Is progesterone widely used or abused? Because we see some of the patients, especially aortic patients, put up on all sorts of progesterone, oral, whatever is available. So they want to prevent preterm labor. Are you justified in using multiple doses and multiple methods of using progesterone?
No.
So yes, Please go ahead, Sunita.
Yeah, I think as we discussed, such high dose is not required, ma'am. 200 to 400 milligram vaginally, as we said, would be better to continue in high risk patients like the so-called ERT patients we could put. And we have been using 17-hydroxy progesterone, and it's proved to be good. But off late, the studies have said that it's not that effective like vaginal progesterone.
it has come back, Rupa, it come back.
Yes,
That
it has
study
come back.
no more. We can use 17-alpha hydroxy progesterone very safely.
Yes,
In
ma'am.
between,
No,
around say, for a period of 1 or 2 years, they were telling not to use.
Yes.
But now it has again come back, because I personally feel that is a wonderful drug.
Yes, ma'am.
Better
Quite
than,
cheap and
yeah,
but
and the patient
painful,
can
but
take-
very painful for the patient.
No, now we have aqueous preparations which are not
Aqueous
painful.
solution, yeah.
Previously, they
But
were oil.
aqueous preparation is not long lasting.
It
Huh.
is
The oily
daily use.
preparation
Daily
only
use.
are long lasting. Aqueous preparations have to be given more frequently.
Yeah, that's true. But at least as against the pain and the risk of an
Yeah.
abscess formation and things like that, it would be better to give a daily or whatever injection than give a painful one.
Madam,
Okay,
one
then
question
what-
is one question is, when you have a patient ART conception on dihydrogesterone and micronized progesterone oral and micronized progesterone vaginal, they come to us somewhere around 10 weeks. Should we stop or should we continue?
Yeah, by 10 weeks. 10 weeks. See,
No,
Because
once they
they see
conceive, they
they-
continue.
they-
Yeah.
They most often see them till 10 weeks and then refer either to the consultant who has referred to them or their consultant of their choice. So it is very difficult to take a decision to stop. And if we stop and patient lands up with an abortion, then we are blamed. So what does
as
the
an
evidence
ART
say?
consultant, I think Bharati will also accept that we want to safeguard the fetus at least up to
Yes.
14
Yes.
days. So,
Yes.
It's 14 weeks. So better to continue till 14 weeks.
Better to
yes,
continue.
14
Yes,
weeks.
14 weeks.
And
Then, of course, we can always tell them that one progesterone, anyone in the adequate dosage, not 100 milligrams or something, 200 to 300 milligrams per day, or injection hydroxyprogesterone caprate once in a week or 2 weeks. I
Once
think,
a week.
yes, that should be the ideal management we should
Those
give the
I
message.
agree.
That should
I'm
be the message.
I'm not an ART practitioner, but I think dihydrogesterone is a better drug to continue because it has other immunomodulatory
Yeah,
effects.
yeah, true.
It
I was
doesn't have-
about to tell you this. Dihydrogesterone especially is useful in previous
Yes.
history of abortion. And
RPL,
now it
in
has
the
been
recurrent
licensed
pregnancy
even for
loss,
preterm
it's good.
labor.
Yes.
Yeah, even for preterm labor, they are telling that we can give dihydrogesterone up to 37 weeks. Okay. Then what are the recent developments, Dr. Subha? Go to the next slide. Next to
Yeah.
the slide.
So we all know that the etiology of preterm labor is related to, inflammation, infections. So we have inflammatory markers and also other biomarkers, which we have already discussed, the fetal fibronectin, which are useful as predictors, So, but the thing is, yes, how many times you're going to do, when are you going to do, or when she's come in labor, are you going to do that? That is the question. And maybe they're not very freely available, but since we have some of these interleukins and all, there's all cytokines which can be measured, and we already spoke about the qualitative and the quantitative fetal fibronectin, which we know that it has a good negative predictive value. And of course, Madam also mentioned the QUIP app, which is a clinical prediction tool. So these are all the things which can be used, which are the newer things, which can be used for, predicting preterm labor. And of course, the negative predictive value will become very important when we look at these biomarkers, the phosphorylated insulin-like growth factor binding protein 1. And these measurements will tell us, whether, because they are all inflammatory markers in the cervicovaginal secretions and released by the choriodecidual junction, because then when there is a shearing force between the membranes and the deciduals is when they are released. And therefore, it will help us in predicting the possibilities of preterm labor. So these are the new things which are there. Some can be easily done, some can't be easily done. fetal fibronectin, we have a slide test. So that is one, I mean, a ELISA test which can be done. So these are all new predictors for preterm labor.
Next slide. I think this also we have discussed.
discussed, yes.
Preterm labor. Okay, then move on to the. So this you move on. This regarding the sonographic, newer sonographic approaches also we have discussed. How the dynamic sonography.
Yes, dynamics.
Yeah. Then the uterocervical angle measurement at 16 to 23 weeks, that is very, very important.
Yes.
Then from the that is again that
sludge.
Flowing sludge, some floaters in the amniotic fluid. They are also independent predictors for preterm birth.
Preterm labor.
Yeah. So
Bharati madam, I have a doubt. Can I interfere?
Yes, please,
Ma'am,
Raj.
what is the role of encerclage in patients who have conceived by ART techniques and are having multiple gestation, twin gestation to be specific? Because
no.
do we rely solely on the ultrasound finding or go ahead and do the
serial ultrasound?
See,
Yes.
only indicated cases you do the cervical encerclage for multiple pregnancy in
Not routine.
Otherwise, they are not going to help.
They are not routine. Routinely not necessary.
Not as a routine, we should not do it, because if you are going to do it as a routine, that itself may provoke preterm labor. Don't do it as a routine.
Madam,
Only-
I had one point for all of you all. I mean, one question for all of you all. This was an ART pregnancy, IVF, twin pregnancy after 11 years of, trying and whatever. Then it turned out to be a twin pregnancy, and the cervical length initially was 3 centimeters. But in the NT scan, it has come down a little to about 2.7 centimeters. So the infertility specialist has advised embryo reduction, saying that you will have a preterm delivery.
Oh my
So
God.
from twins, let us make it singleton.
Never.
This is also not
No role for
justified.
fetal reduction in twin
Not at all
conception.
justified. That's
Madam,
not
twins
right.
are
For
never
that person,
reduced. Not to be reduced
since
at
you're
all.
pregnant and you're okay. And her point was, she's insisting. She's saying, you have to listen to me, otherwise you will have premature this, that, and all.
No,
I said,
no.
since you're pregnant now, you can leave her and go to any other doctor.
Yeah, very true, very true.
Then maybe
If it was triplet, I would have said, okay, you can reduce to
Triplet, yes.
twin. But where
Was
do
it
you
triplet?
Yes, but twin,
Was it
no.
triplet?
twin? No,
Triplet
and
we are
that was just for an
justified.
ultrasound reduction in the cervical length, that too at 12 weeks. I said, you wait and see. You can get a stitch put. You're already
Yeah,
on
14 weeks a stitch can be put if
Yeah,
it's reducing
but
still.
not
Yeah.
embryo reduction.
Even instead of stitch, simple Arabin pessary can help. Somebody
Yes,
has asked
yes.
in the
Madam,
chat
there is
box
a question.
where it is available. It is
Madam,
available very well in some of the companies. I
It
get
is
it from
available.
Chennai. It
Hmm.
is available, but it is
You
quite
can
expensive.
you can
Quite
put the
expensive.
address. And some
Uh,
research is also going on, no? Whether they can support for the research this Arabic
yes.
pessary. Yeah.
I have had more than 30 patients with Arabin pessary and only one expel. Rest of the
Okay.
patients we took to. I was able to manage.
please share the contact, madam, so that we
I
can
don't
post
have that currently, but I
later
can.
on, madam. Later on, we will
Yeah.
put it in the
Yeah,
group.
yeah, definitely.
Put it in the
I'll put
group, madam,
Yeah, yeah.
because I will tell this girl to use the Arabin pessary.
Thank you,
Yeah.
madam. Thank you.
That will be good. That will be
Yes.
good, but it's comfortable also for the patient. Actually, I had one ART conception. She had 5 spontaneous abortions, and the last one was that was an ART conception. And I initially put her a stitch. No, then she was about the patient whom I mentioned earlier. The stitch came out. It did not. It was not proper, and then I put in an Arabin pessary. Then after a week's time, I could see the beautifully formed cervix.
The cervix like
So
that.
again, I put in a stitch, put in an Arabin pessary. I was able to take her to 36 weeks.
That's what. Good experience, madam.
Yeah. So
now,
it's all trial and error. We have to act according to the situation. So then comes the last one. There is a role of omega-3 fatty acid in preventing early and any preterm delivery. Have any one of you tried this?
No.
This
But
is a
nowadays, in the first trimester only, we are giving folic acid with DHA to
DHA. Yeah, we're giving with DHA.
And of course, vitamin D, vitamin B12, everything people are doing, and they seem to be taking all that in their pregnancies. So we don't know whether it is helping the PIH, whether it is helping reduce the GDM, or whether it is helping reduce the preterm birth. I don't know.
Or at least it will improve the nutrition.
No, there are
of the
many,
mother.
many studies,
Of the
Dr.
mother.
Ramani, about this omega-3. And
Ah,
I've gone through, but personally, as such, I have not used because we have to stratify the risk factors. No, so many times it may not be only nutrition,
Yeah.
it might be something else. It will not
Yeah.
lengthen the cervical length, right?
Yeah,
Only-
not the
Maybe the
cervical.
maybe the collagen
Yeah,
may
maybe
improve to some
collagen
extent.
somewhere it is effective. So
Molecular
we
level.
can give that as a empirical.
yeah.
No,
that's-
and traditionally, all the pregnant ladies were given walnuts and almonds and whatnot. You know, these are all the content is all
Of
these things
omega-3.
only. Yeah.
Mainly fish eaters.
So finally, the research on vaginal microbiome. Everywhere, any disease
Probiotics.
pointing more towards the microbiome and specific vaginal metabolome and microRNA. See, these microRNAs are signature RNAs for each disease.
Yeah.
So they can predict the preterm labor. So particularly, we have more than 2,500 microRNAs that are circulating in the body. And each disease, for example, for PCO, you have a group of microRNAs.
mRNAs.
And for endometriosis, it is few. So similarly, for preterm labor also, there are certain signature microRNAs which are dysregulated. So by application of this, we can predict to some extent. And I think the first trimester maternal serum advanced glycation end products, that is AGEs, levels were significantly higher in cases complicated with preterm labor. So these are all the fewer places where we have to go for a research. So ultimately, finally, I thank my co-moderator, Dr. Bharti Rajshekhar, and my dear Vidya Duppi, and all my dear panelists, Dr. Rajeshri Palladi, Dr. Sunita, Dr. Subha, everyone. Thank you so much for taking so much of active participation in this.
Thank you, madam. Thank you.
Madam, there is another
Thank you.
question. There is another question in the chat box asking, Dr. Pooja Jain wants to know the brand name of probiotics. I think in webinars we are not supposed to talk about that. Well, the dose it is usually Lactobacillus racemose and Lactobacillus, which comes as a compound.
Combinations.
Yes, combination, and this is usually given at a dose of twice a day for 2 weeks. Twice a day for 2 weeks.
For some of my patients for recurrent preterm and spontaneous abortion, I've even continued up to term.
Madam, I give it in the first trimester, and then I repeat it again in the late second trimester. I give them 2 doses.
Yeah. And if I may add, see, all these probiotics are very expensive, but lactobacillus is the only cheap ones, you know. So one of my mentors, a very senior person, had said, ask them to break the Sporolac tablet. Sorry to use the trade word, but you ask them to wet and break the Sporolac tablets and insert it into the vagina. So that will help locally lactobacillus. That's what they said. So I think that's again a good idea. A less affordable patient, we can ask them to
that. And even incorporating buttermilk, yogurt in their diet is also going to help them.
Correct.
Then
and
one more
question,
whether
people have been using that for douching also.
Yes, that's what they say.
They've been using it for douching.
True.
Probably that will correct the vaginal microbiome.
Yes.
So there is one more question, whether we can combine the isosuprin with magnesium sulfate. Better not. No two beta hematics or tocolytics should be combined.
Beta mimetics.
Yeah.
Pulmonary edema can increase.
Edema can precipitate. And similarly,
Best is indomethacin whenever you want to give. That too in emergency, of course. We can give indomethacin till that steroids act.
Yeah, but indomethacin is a good drug for
Hydramnios.
multiple pregnancy associated with hydramnios for preterm labor.
Polyhydramnios.
Madam, your input about using routine or prophylactic antibiotics to prevent preterm labor.
We said no already.
No.
I think it was said no.
So universal opinion of the panelist and the moderator is no.
Dr. Durgadas,
it disrupts the vaginal microbiome and causes no problem.
True. Dr. Durgadas, your final word.
Agreed. He has also agreed not to
Everything
use.
is covered. Actually, I give probiotics in high-risk patients every month, 10 days
Yes,
oral
sir.
thing.
That's
Every month I
it
give,
definitely
starting from
helps.
the second this thing up to the
clinic.
station.
I want one more opinion about the maintenance tocolytics. We always tell that we give tocolytics till the steroids should act. And sometimes the whole study pattern, whatever I described, there are studies that they have given till 36 weeks. And earlier, I remember during my postgraduates, Dr. Rupa, you have to unmute yourself. They
Dr.
used to
Rupa, please unmute yourself.
Yeah.
No
They used to give till
tocolytics for a
36
longer
weeks.
time.
We used to
Longer
give
time.
it throughout pregnancy, never
No,
had
no.
peripheral cardiomyopathy during
used to
our
give.
PG days.
Yeah, if at
so
all you
I
want to
want
give a tocolytic, you change it to progesterone.
Progesterone can be given up
Glutamatic
to
will
4
be given
weeks.
for a longer
No,
time. beyond
progesterone we
40.
are giving till 36 weeks.
Yeah, that can, I think that is sufficient.
Isoxsuprine also can be given till 36
No,
weeks.
no, no, that is
prolonged. No.
Ma'am, 1 minute.
cardiomyopathy.
Medium on the rise.
We
Medium
used
on
to
the
give
rise.
it, but it is not to be given. Give progesterone, and if she goes into threatened preterm, a short course of isoxsuprine, and then stop it.
That's what take-home
Yeah.
messages.
It has to be stopped because
acute preterm labor can be stopped with these
Yes, that's it.
tocolytics, and then
Yes.
maintenance should be given
progesterone.
progesterone. Yes.
Yes.
Progesterone and lifestyle modifications and tender loving care.
Yes.
I know
Another doubt
TLC
is
is
whether
the treatment for
progesterone
everything.
induces DDM. Another
What?
doubt is whether progesterone induces or accelerates the process of GDM.
No, I don't
No,
think
no,
so.
no.
No,
But
Isoxsuprine, ma'am.
definitely
Isoxsuprine.
accelerates the GDM. Isoxsuprine accelerates.
Isoxsuprine.
see,
Because it's
beta
a beta
mimetics
blocker, yeah.
increase and
Beta
also
mimetic.
that is isoxsuprine, and also for the fetus, the neonate,
Hypoglycemia.
yeah, it causes problems, hypoglycemia.
Yes.
So, Dr. Ramani Madam, it was an excellent panel covered.
Yeah,
very
so
well.
much nice discussions.
The panelists did extremely well and given the right points to take home, and I think the audience also has been got very clear points to take home. So I would request Dr. Ramani Madam to conclude the session with her key take home messages.
So first of all, let me thank Kasoga for giving me this opportunity. Okay, then my take home for preterm labor is one is any pregnancy is prone for preterm labor. Always have a vigilance. Correct all the basic nutritional deficiencies, and we have to look into preterm labor in high-risk patients. So when you book a patient, you take a checkpoint to see who are all the patients that having high risk, like a previous spontaneous abortion or previous preterm labor. That we have to make a note. And then in the current pregnancy, you during the first trimester and look at the cervical changes and all these things, follow them subsequently. Then again, you have to have a vaginal swab, urinary tract infection has to be corrected. This is from the maternal point of view. Then they should have a frequent periodic antenatal checkup. That is very, very important. And if the patient is put on progesterone, it is ideal. You can continue it. Probably beyond 16 days, I prefer changing the oral micronized progesterone to this one, hydroxyprogesterone caprivate. So that is, then you have to definitely give them antenatal corticosteroids are indicated. And then look for periodic cervical screening, and every visit, every trimester visit, you do a urine culture test, correct anemia, correct other nutritional deficiencies. Then follow up the patient. If the patient gets into, and you have to decide whether the patient needs a prophylactic encephalage or not, depending upon the history. Then emergency encephalage, as always, it should be thought about, because even a single day in utero presence of the fetus will reduce the NICU incidence, admission into NICU. And then better if the patient is showing evidence of preterm labor, use tocolytics for a short term, then follow the patient with progesterone. That will give us time for the in utero transfer to a NICU unit. Then magnesium sulfate should be given for neuroprotection. But two things is you don't combine magnesium sulfate with the tocolytic. And beyond everything, tender loving care. like sir has said, microbiome, this probiotics can be, that is also going to be of use. And I don't think we need to go for checking up fetal fibronectin, which are all very expensive. Our clinical judgment and use of CTG in later pregnancies can predict us whether the patient is in active labor. I mean, uterine contractions are there or not. Then speculum examination, avoid vaginal examination. Pervaginal examination should be avoided. And better to deliver in a place depending upon the gestational age where NICU facility is available. I think these are all my take-home points.
Thank you. And Madam, one more, I think if we have effective preconceptional counseling for all those to-be mothers, I think that is going to be one point which will definitely reduce the incidence of prenatal death, delivery and its morbidity.
Yes.
I think that's where we have to make a beginning now for adolescent health being improved.
Ma'am, one more question, ma'am. Ramani, ma'am, even if the counts are 20,000 above, you go ahead with rescue cerclage at 30 weeks, ma'am. When the counts are high, I believe until proved otherwise, preterm labor is a part of infection. So
Yes,
even if the counts are high, you go ahead with rescue.
But see, these are the patients, if they have a very high total count, when we go for emergency encircler, they land up with preterm.
Yeah, because already there is an infection.
Yeah,
the presence of infection, you are putting
infection is the reason for her premature delivery. So those patients, they will not respond. They will.
So you can wait. You can wait for 24 hours and give them an antibiotic, probiotic, and counsel them, and then take them up. Not immediately, soon as they come.
Maybe this is the case where we can give tocolytics, magnesium sulfate, whatever it is. Put them in slightly in a headlock position.
Red bug position.
Actually, we formulate the term like cervical insufficiency. And they say that for this cervical insufficiency, there is some subclinical infection.
Inflammation.
That's the most important.
We don't do amniocentesis as such. Actually, in other countries, they do amniocentesis and find out whether there is really infection. But we are not doing. We are just give empirical some sort of treatment. And,
I feel, ma'am, neonatal sepsis will increase, like unnecessary prolonged. So, like
And
one
that,
day in utero stay will increase the neonatal sepsis later, ma'am. What do you
So we
feel
have to
about
balance the
neonatal
seesaw.
sepsis.
We have to balance the seesaw. Yes.
Yeah,
So
not
that
only
is why-
neonatal sepsis, I have had patients with maternal sepsis. And
Maternal sepsis also is very, very important.
Yes.
That is
So the presence of sludge in the amniotic fluid, and also years back they used to say absence of fetal breathing movement is a sign on ultrasound, is a sign of patient going into preterm labor. So many a times when you do 28-30 week scan, if it is reported, I think we must give a little credence to that.
Yes.
Thank
Okay.
you.
Many
Thank
things to
you so
learn
much.
from today's panel.
Yes, over to
It
you,
was a
Dr.
great
Vidya Prabhi.
discussion, Dr. Ramani. Yes.
And I must,
Dr. Durgadas, you want to comment?
before Vidya says, let me just thank Vidya,
Yes.
Rajeshri, all of you to having me on this webinar, and of course Dr. Ramani madam, that was a really great, and of course
Very
Bharti,
interesting.
it was a very nice moderation and a good webinar.
Thank you. Thank you, Dr. Shubha.
Thank you. Thank you so much.
Thank you, ma'am.
Enjoyed
Thank you all my
I
panelists.
invite suggestions because this was the first time I tried one focus topic, one talk, and the second is panel. So all panelists from our state, from all the zones, and the speaker should be from the other state who is on that any subject. So please, I invite the topics, and then Bharti and myself, we will decide how to go ahead.
I'll do it.
So that will be very much focused discussion. So once the elections are over, we will do every month one Gyana Sangam on this this week. Okay.
Actually, this is nice because for students, there was a revision.
Yeah, the
Initially,
whole
Vidya spoke about preterm labor, and same things were emphasized again. If a student postgraduate has attended, it is really good to answer a long question and discuss case in
they
their
can
exams.
write also. They can write the
not only students, it is a revision even for the consultants.
Consultants.
A lot of
we have to read, no?
lot of cobwebs which get cleaned up in these discussions.
And so many experiences are shared.
Very true.
Like Ramani has used Arabin Pessary, probiotics, how to use all those things. Now let us bring back the Isoxsuprine and try in some patients.
I think Isoxsuprine never went out. Only we people, who are,
But it is a DCGI approved also.
yeah,
Let us try in some of the
because
patients.
I've
But
been
Dr.
seeing
Shubha, we people have
prescription.
been using it. The younger generation have not tried it. We have been
Yes.
using it.
Yeah.
But the younger generation still, because they have
No,
not
but we
exposed to it.
stopped using it, Bharti, because of the so-called complications, and now it has come back.
Pulmonary
Yes.
edema.
And the thing is, even though I have been seeing prescriptions of TAB, Duodilon, 10 milligram TID, all through the pregnancy. But supposedly,
The patient has got tachycardia.
Yes.
Some of the patients, they don't even tolerate. And I was
With
a victim
NMG,
of
they don't have.
Duodenum.
The heart rate goes above 100.
yes,
Yeah.
it
Be
does.
very, very careful. Headache and this problem they have. So I think, Dr. Vidya, we can conclude.
Yeah, we can conclude. Dr. Suman is here. Dr. Suman Gaddi, our dear treasurer. So she will conclude as well as she will give the vote of thanks.
Yeah, thank you very much and good evening one and all. It was a very elaborate and very interesting discussion on preterm labor and tocolysis. So I first of all congratulate Dr. Vidya Topi to get in such a wonderful topic, and of course we learned, the students learned, and it was a brainstorming session, definitely. I would like to first of all thank our patrons, because of which we are here, and with all these webinars and programs. I would like to thank Dr. Vidya Tobi, Dr. President, Dr. Bharti Rajshekhar, and our secretary, Dr. Rashi Paladi. The experts of today's webinar, Dr. Vidya Tobi and Dr. Durga Das, they did a very great job. Moderators, Dr. Bharti and Dr. Ramni, Dr. Ramni Devi, who was our chief guest also, of course, made it very, very interesting. And we thank our panelists who participated and did very well. They were really learned. And panelists, Dr. Rashi Paladi, Dr. Rupa Prakash, Dr. Rajeshri Aliwal, Dr. Sunita TH, Dr. Subha Ramarao. And of course, I would like to thank all delegates who have attended this session. I thank the sponsor, the Abbott Pharma, and of course, Mr. Arun, who has given us the Zoom platform. Thank you, and good evening, one and all.
Thank you. Thank you.
Thank you, Dr. Suman, and thank you, Dr. Bharti. It was a really great moment for me also. Thank you, Dr. Ramani, and all the best for your future. And those people who have joined outside state, I can see many people from Tamil Nadu also. Those who are from other societies, please vote Dr. Bharti Rajshekhar, Dr. Kasturi Donimat. Dr. Bharti Rajshekhar is for Perinatology Committee, and Dr. Kasturi is for Quiz Committee. So please vote for them. Thank you very much for joining, and see you again in our next academic session. Thank you.
Thank you very much.
Thank you.
Thank you, Sunita, Rupa, everyone.
Thank you, ma'am.
Yeah,
Thank you.
Thank you. Thank you, Dr.
Have a
Gurdas.
great
Thank you.
weekend.
Thank you, Vidya.
Yes.
Thank you.
Thank you, Arun.
Thank you for your presence throughout the webinar. Thank you, sir.
Thank you. He was always there. Thank you, everyone. Thank you. Thank you, Ramani.
Thank you, Vidya.
Ramani madam, thank you, madam.
Thank you.
And
Thank you.
I appeal everyone to become ICOG member.
Yes.
Yeah.
If they
So
are
my
not there.
first thing is, I just want to, once when I become the vice chair, my aim is to make all the members of ICOG.
Yeah.
Yes, madam.
Take the academic standard of Foxy to,
Sure.
to take it
That
to a
is what.
greater height.
See,
True,
That
true,
is
madam.
my
Very
main
true.
we should
thing.
have that.
You will
So
definitely do it,
everyone
madam.
from
We are all with you.
Karnataka, we will increase the base of ICOG. We are having KCOG, our own academic wing. Yeah, we have that also. Okay, then.
Okay, madam. Thank you.
Shall I ask Arun to end the meeting?
Yes, yes.
And everyone will get from Kasoga certificate of attendance with KCOG points. Yes, thank you.
Thank you.
Thank you very much.